example of a de novo disease where the majority of the variants happen just in this child and it will not reoccur. However, these children with achondroplasia, they can reproduce, they can get married, they can become a normal adult, and they can get married and have children. And then because it's autosomal dominant, then the risk of having the recurrence based on 50%. So the last two slides basically is showing classical examples of autosomal dominant disease, and they present one disease present lifelong. They can reproduce, have normal lifespan. The other one is more of a de novo disease, which is achondroplasia. Now, the other disease that can be also misdiagnosed, and it's very important for us as a geneticist to know and to distinguish. It's called osteogenesis imperfecta. The reason why we get frequently called as a geneticist in the ER, that the child will present to the ER with multiple fractures. Then the ER physician will be questioning, is there a child abuse or no, because of the multiple fracture. And then usually and frequently we get called as a geneticist to come and evaluate the child. And the reason why we need to evaluate the child is this a disease that involving the bone, like osteogenesis imperfecta, or it is a true child abuse that is causing the fracture. The mode of inheritance in this disease is a recessive. And the other thing why this disorder needs to be recognized, there is a treatment, or that it's called bisphosphonates, and it's very important. One, it's not real child abuse. Two, there is a treatment or management for this condition, and it's very important to recognize this disorder and to start the management as early as possible, which will decrease the complication and the severity of the disease. Then another very important syndrome, which can also have a prevention. It's called Brugada syndrome. And recently, there is a very large attention and by the cardiologists in our country. I can see, I noticed in the social media, there is an increased attention to these syndromes, which basically are causing syncope. And at the most severe, it can lead to something we call arrhythmia, where the ventricles or the heartbeat will be very fast, and then the heart then will stop. And this will cause a sudden death. And why it is important? Because usually the first presentation for such syndrome will be in the family, will be death. However, that will be the first presentation. And then the patient will come to your clinic with a family history of a sudden death. And how many of us, we have a family history of, we know someone or we know a family where there was a history or a sudden death? The most important thing is in these families, it's a dominant disease. So each individual in the same family have 50% risk of having the same disorder. And we, as a geneticist, we need to make sure it is really not a Brugada syndrome, or in general, we call it long ventricular arrhythmia, and then the sudden death. The other problem is the ages. It could present from 2 days until 85 years old. The sudden death, usually the average age is 40 years. And why it is important to recognize this syndrome? One, we can do testing very easily. Then we can identify the people who are at risk of having this Brugada syndrome and start to prevent the arrhythmia. The other thing is that we want to, another important syndrome that we need to know or we understand, because it's also demonstrate an important concept in genetics. It's called androgen insensitivity syndrome. The mode of inheritance in this syndrome is autosomal recessive. The most important part, or why this syndrome is important, because it also shows that the karyotype of this individual will be 46XY, is a male karyotype. However, in the complete type of androgen insensitivity syndrome, the phenotype would be completely female. while the karyotype will be completely is a male. And usually the endocrinologist will follow up these patients, and then the endocrinologist will not tend frequently, maybe, or they will not order a karyotype as a part of the evaluation. They will do hormonal tests, etc. But karyotype is important to assess these individuals, and because also in the partial type, there is a risk of testicular malignancy, and if we identify this individual early, then there is an intervention or treatment can be provided. Now, these are the all syndrome that I talked about in the last 10 minutes wasn't syndromes with an important clinical presentation, or clinically as the patient, they are very important from the clinical point of view. In the next few slides, I will be talking about syndromes. They are still clinically very important, but the specific thing about them, they demonstrate a special concepts in genetics. For example, the first one is called Fragile X. Fragile X is a disease that is inherited in X-linked, so it's in chromosome X, and we call it triplet repeat. It's very important concept in the genetics, the triplet repeat. What does triplet repeat means? The sequence or the DNA sequence in the chromosome X, which is located here, this is the gene name called FMRP, and then in this gene, the normal gene, there is a CGG, 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 so it's a triplet, 3, CGG, and this CGG is repeated between 5 until 44 times. So like CGG, CGG, CGG 5 times, up to 44. Sometimes there will be an expansion. So the triplet CGG, the normal is 5 to 44. Then it can expand to a level called intermediate, or go to the pre-mutation level, which is 200, from 59 to 200. And then the mother, because it's an X-link, if the mother in this pre-mutation zone, then there is a risk of her child, the boy child, to the number from 60 or 70 could expand to more than 200, and then the disease will happen. It's an X-linked disease involving triplet repeat expansion. It's not just a straightforward X-linked disease, and there are many other disorders with the fragile syndromes that represent important concepts and that we need to know. They're called Prader-Willi and Angelman. These two different syndromes, they are brothers and sisters, and they have a different clinical features and the clinical presentation. However, at the molecular level, at the genetic level, they represent another very important concept. A concept we called it imprinting. Or what does imprinting mean? Imprinting means that from each one of us, we need 2 copies to express. We have 1 copy from the father and we have 1 copy from our mother. In any scenario, if we lost one of the copies from our father, or we lost the copy from the mother, then we have only 1 copy. Then the disease will be manifested. For example, here in the Prader-Willi syndrome, this is the normal scenario. We have 1 copy from the father and 1 copy from the mother. And then if for any reason this copy from the father gets lost, then we will have the syndromes called Prader-Willi syndrome. What is the possibilities of this paternal copy will be lost? 1, it's a deleted. 2, something we call UBD, means the 2 copies came from 1 parent, either from the mother or from the father. 3 is an imprinting defects. The same thing for the Angelman, they are in the same location. This is exactly the same location at the chromosome, but if you get the father contribution lost, you will get Prader-Willi. If you get the mother contribution lost, then it will be Angelman syndrome. And then, for example, in this example, we see there are 2 copies from the father and no copy from the mother. And this is again called UBD, means the both copy from this chromosome inherited from 1 parent. Then triploidy, I'm sure you heard about this. This is a chromosomal disorder. It's not autosomal dominant, it's not a recessive, but it's involving the chromosomes. And it's not like you heard about Down syndrome, where there's an extra copy from chromosome 21. What if we have an extra copy from all the chromosomes? Then the number of the chromosomes will be 69, and this will be called the triploidy syndrome. BRCA1 and BRCA2 are two important genes that are involving in the breast cancer, and as a working in a healthcare, you need to know these syndromes very importantly because it could lead to inherited breast or ovarian cancer. Now, in the last 3 minutes or 2 minutes in the last two slides, that I will be talking now the diseases that are common in the population. This is a list of diseases that we have seen, and these are the more common disorders that are frequently encountered or we seen in our population. For example, we think the most common disease is congenital adrenal hyperplasia, followed by G6PD, then congenital glaucoma, and then the list. Sickle cell disease and beta thalassemia, which is part of the premarital screening, فحص ما قبل الزواج, is actually in the list is 1, 2, 3, 4, 5, 6, 7, 8, 9. It's number 9 in the list of the common diseases in our population. At data 3, one of the most common cause of mental retardation is above this list, but it's not included in the premarital screening for different reasons. Then, how about the metabolic diseases? These are the list of the most common metabolic disease in our population. And again, if we talk about the newborn screening and what are of these diseases are included in the newborn screening, we would see two diseases only are included, the VLCAT and the biotinidase deficiency. However, there is a long other list that are not included, and there are different reasons or explanation why it's not possible or why we are not including these diseases in the newborn screening, for example, in Saudi Arabia. So again, this is the first slide is most of the syndromes, and this one is more of the metabolic disorder. I think
thank you, Dr. Ahmed, for this wonderful presentation. I don't want to cut you in.
I'm done.
It's very informative. Good, good. Okay, so for all the questions about the topics, after each session, we're going to have 10 minutes for the questions that are asked to the doctors. Now for our second topic, which is utilizing the Saudi Genome Project for clinical diagnosis, given by Dr. Malak Al-Thaqafi. Dr. Malak Al-Thaqafi is an American board-certified physician scientist in clinical pathology, anatomical pathology, and neuropathology. She is also in molecular genetics pathology. She studied and worked in world-renowned universities like Georgetown, University of California, San Francisco, Stanford, Johns Hopkins, and Harvard. She is a national and international awards winner in her field and published over 100 papers in prestigious peer-reviewed journals and conferences. She has multiple books, and she is a general director of National RDI coordination. She's also a consultant physician in molecular and neuropathology. Please start, Dr. Malak, and welcome to the talk.
Thank you. Assalamu alaikum jami'an, and كل عام وانتم بخير. Thank you very much, dear Lama and Professor Amal, for this kind invitations. Very wonderful talk, Dr. Ahmed. And some of the syndrome you mentioned, it's very close to my heart for different reasons. So today we'll talk about Saudi Genome Project. It's one of the projects probably some of you worked with us closely. And the idea of this in the first one of the phase of Saudi Genome Project, and what's going to happen in the phase 2, and how you mostly as a genetic counselor this project can be helpful for you or can use the resources of it. So let's see. So I will start with the slides just to think in general. Now let's forget it. The future of medicine in general is very complicated, and it's becoming very hard to secure a sustainable healthcare system. And this will affect each specialty, either we like it or not, including genetics, clinical genetics, laboratory genetics, genetic counseling, etc. We have different challenging. We listed it, some of here in the top, was trying to give this hard this hard balance between giving affordable care, yet to have equal access and high quality care to everyone. People with different conditions, including inherited disorders or diseases that are caused by genetics. And as we know, most of the diseases that has some genetic reason, they are not inherited, but they're caused by some sort of genetics mutation. So here, what we're trying to move from the population health, making one size fit all, trying to go to more personalized care, more preventive care, more actually real health care, because as you know, today's what we're doing is mainly actually disease care. We're looking for patient, we manage patient after they got the disease, and sometimes very late. So this is personalized precision medicine. That's what we mean. In simple word, we're just taking account the variability in genes with environment, lifestyle for everybody. I like this traffic light. This is how genomic application can play a role in three things: prevention and screening. And as Dr. Ahmed illustrated in many important program, premarital newborn program, screening program, etc., cancer screening program, prevention, we want to prevent them. And also want to make sure we make the accurate diagnosis using the latest technology we have these days. And also, although we're very shy in the therapeutic part, we're starting to see some sort of gene therapy or enzyme therapy, and we're hoping more will come in the future, and more with the CRISPR and gene editing, etc. So why is this important? I hope this paragraph, this cartoon on the left side tell you. So this is what happened usually in the upper left side. With traditional diagnosis, we really caught the disease very late, at the point where it's actually disease care. So we only time to give therapy, sometimes it's too late to give in some diseases. And this is a direct association between when you discover the disease and the quality of life. So what we want to code them here, as like when we use the genomic application, different tool to improve the quality of life by trying either to prevent them or detect them early. So that's why it's important for all of us to know some important features, or to use genomic tool to do that. This is a slide, as you know, after the Human Genome Project completed 2003, there was few years later, there was booming in the sequencing technology, and the prices went down very quickly, which allowed many countries to establish their national genome project. Each has a specific reason, and some reason they're shared between different population. Saudi Genome started in 2013. I like also to always to show the UK genome as an example, because it started a year or two before Saudi Human Genome. We had similar kind of objective by sequencing 100,000 genome. They were keen to look at rare diseases and also at cancer, and they wanted to kickstart the development of genomic industry. We have similar model because we have different facilities like them, although the budget is way lower than what they had. And they have some achievement, what we can learn from it. It improves their diagnostic ability for rare diseases and for cancer, and even some identifying some treatment, especially for cancer patient, because for those who are not in the field, most of this targeted therapy actually now is in the cancer field. So this is what's important, as well as they have this, what we call it, and genomic industry, which it has an impact in UK economy. So what we did, Saudi Genome was launched by the end of 2013 by KAXT, trying to sequence the same number of Saudi, focusing on discovery, knowing the common diseases, provide infrastructure, and implement the personalized medicine healthcare in the kingdom. What we did, we are up to date sequence up to 66,000. Now there is different reason why we did not reach the 100,000, but it's not a time for it today, but we consider it as a success. We have different collaborating centers around the kingdom. We call it satellite, and we were able to have the infrastructure, train people, and we in the first phases in having this as an industry for the kingdom. So those are the centers, some of them in Riyadh, in Jeddah, in Hail, in Medina al-Munawwara, etc. So why we want to do this? Very many different reasons. You know, Saudi is one of the highest, has one of the highest incidence of genetics disorders, especially monogenics and metabolic disorders in the world for different reasons. So we wanted to improve the quality of life for these patients by knowing what's common, designing new screening program, trying to make more preventive efforts, as well as trying to help in the future of genetic therapies. Why also? Because we wanted to get into this industry. It's very rapidly growing, and probably all of you with COVID understand, although some people think about it as infectious, but it actually was driven by the genomic industry, from the vaccine development to diagnostic to sequencing, etc. So how it works in the Saudi genome. So this is, it's very routine standard. Basically, CACS gives the infrastructure for the satellite sites, training, each institution responsible about the ethical approval for their project. Center can work with each other, and they have to submit their result to a national center database. This is the capacity. This is how it started, only one platform. The size of data generation, it expanded quickly when Crown Prince Mohammed bin Salman launched the new platform and the lab in mid of 2018. And this is the size of data we can generate. So the Saudi genome is a little bit different than other national genome, because most of the other national genome, they started actually either to do a whole exome or whole genome directly. It was designed to start with gene panels to give a quick turnaround time, and also trying to build on previous expertise. Later, when we have the multiple other platform, now we can do a whole genome and whole exome. And as all of counseling come in different part of this, from the lab, working in the lab, and also working with the families in the clinic to get appropriate history and pedigrees analysis, etc. So this is the central core lab in the lab. This is all the machines they have. They can do genotyping. They can do next generation sequencing with different platforms. They can do Sanger validation. Satellite side only have one sort of platform that can be able to do panels or exome at a very small scale. And everything gets secured and stored in the central computing facility in CACS. So this is, we're making sure that the privacy and the security of the data in a very safe hand. Okay, now you ask me, so what can we do with this data? It's obviously for three things. First of all, acquire knowledge. And this is led by a team of scientists, physicians, counselors, technologists, families, patients. All of them work together to build this knowledge for the kingdom, either discovering new variants or disease-causing variant, enriching the international databases, getting correct number of the prevalent of diseases, etc. And this has helped us in the first experiment to enable diagnostic, which I'm going to explain, and with collaboration with labs in King Faisal Specialist Hospital, and also help a team on the Saudi genome to design program to enable prevention. Why is this important? Two things. We want more accurate, more precise tests to be happening in the Saudi, and also want to make sure all the data ownership stay in Saudi and be secured and be available for all the scientists to build on, especially with the booming of artificial intelligence and machine learning technology. This slide, again, is just putting you outside your comfort zone. Genetics is not only about a Mendelian kind of inheritance or triploidy or some chromosomal abnormalities. We know genetics, it's in almost every disease. This study came from Lancet in 2017, and even the updated one, which I did not have time to update it, showed you the top 10 causes of daily. What is daily? Disability adjusted life year. That's mean these diseases can cause people not to go to work, can decrease their productivity. And 8 of the 10 of the top 10 actually had genetics had to do something with it, either a direct or indirect way. So what we did with the lab in the first phase with the piloting study with local lab and diagnostic, most of you worked with it, and they designed different panels that have been used by many hospitals in the clinical setting, and it served almost more than 30,000 samples, and it was had its pros and cons, but it was very successful enrichment experience in general. It was designed for Saudis based on the database from Saudi Genome and referenced by Saudi Human Genome Database. Now, another topic where you can, and of course, in here we had a clinical genetic counselor and also worked very closely with multiple genetic counselors in the hospitals around the kingdom. Another important topic is cancer. Cancer is a genetic disease, and as Dr. Ahmed showed you, BRCA1 and 2 may be one of the familiar one to you because it has some inheritance role on them with BRCA1 and 2 and other gene. But cancer is a genetic disease, which means is each cancer, because it happened because of certain genetics changes or mutation. Now, somatic, most of the time, luckily, alhamdulillah, imagine if it was all familial. It's somatic, but again, because it's somatic, this field of targeted therapy of cancer is very important, and genetic testing cancer are very important. So we also work with Simple Lab just to pilot, although in the phase 1 of Saudi Genome, we did not do a lot of cancer, but we worked with Central Lab to try to enable at least a cancer diagnosis using a next generation sequencing. Again, mainly to correct diagnosis and giving targeted therapy because this is available in market. So it's very similar in cancer, in opposed to inherited disorders, we actually prefer in clinical setting to go mostly with panels. We don't do whole exome or whole genome for cancer in the clinical setting for different reasons. Basically, it'd be very complicated to get fresh sample from most patients, unless if you're doing liquid cancer like leukemia. Second, you need to also do sequencing from normal tissue if we're lucky to get fresh sample. Fixed tissue can be done, but it's very complicated. So we always go with panels. And what we tried with this lab, we tried to do, and here, you're luckily BRCA2 was discovered. But was somatic inheritance. And the patient also have target, one of the PARP inhibitors, so it can be used. So we give them explanation what is the gene and what drugs they can use. It's NFDA approved. So this is what, again, experiment with how to use this data in clinical setting. Last one, maybe this close to the example was given, we wanted to know what is the true prevalence of familial cancer cases in the study. This is a study we established. It took very long time. It was very complicated to start because one of the first important goals for it was actually to start cancer genetic counseling clinic inside the Comprehensive Cancer Center, one of the largest cancer center in the kingdom in KFMC. And we were very strict about having a board certified counselors to run this clinic with the oncologist. So this is a different little module for who people work here, and it was, alhamdulillah, very successful. We finally closed it. We almost achieved our goal, and the results were striking. I will not have time to mention it today, but familial cancer is way more common than what we think in our population, and this is one thing you have to keep eye on it. As a counselor, when you see somebody or family member or family with unusual presentation. So this is example one family. This syndrome become very common between our neuro-oncologists after this report because now they're keeping their eye when they see any kids with cafe au lait spot, an unusual brain tumor. Now they think about CMMRD, constitutional mismatch repair deficiency. It's one of the few actually autosomal recessive kind of inheritance cancer genetic syndrome. Poor family, she has they have two kids, one girl with glioblastoma, a brother who died from a rare type of lymphoma. To summarize, they did not respond to the normal therapy, but our oncologist, because they got exposed to it, they looked, something was unusual, so we tested them and we included them in this study, And indeed, she was positive for the dad and the child for MSH6. And they started immunotherapy, and she survived for 4 years, which is very unusual for glioblastoma. Now, lastly, is the screening program. I told you it's very important when you do this for genetic disorder, trying to prevent, because treatment is not very easy. There is not a lot of treatment for a Mendelian sort of genetic disorder. We try to prevent. So from what we learned from Saudi Genome, all the cases was done. There was common genes in Saudis, and they were designed chip to test individual for their carrier status for all the prospective couples. And it was validated in almost 50,000 cases with almost 100% validation rate using genotyping array. And it has a dedicated center with a lot of genetic counselors who work on this project. I don't want to forget any names, but a lot of them work on this and helping us to make this possible with the Ministry of Health and other parties. Finally, although this one is not very related to your talk, but genetics is also important in COVID-19, whole genetic accessibility and severity. And who knows, and inshallah, this COVID will finish and we don't want to hear about it again. But we're working with some people around the world, how maybe we have accessibility gene run in the same family that gives us some variant, gives them some sort of protection, or make them more get them more affected, get more severe phenotype when they get it. So this is also, we're working on it. And I know I was quick, but it was only 20 minutes, so please bear with me. You know, the entire kingdom is going along transformation and all coming together. And a healthcare system has its own transformation. And there is 4 main areas we work together with a healthcare transformation program. Saudi Genome in the next phase 2, will be crossing with a national health transformation program is 2 important areas. First, improving the quality and efficiency of healthcare system. Second is promoting prevention of health risk, either by premarital, improving newborn and familial cancer screening, and even somatic cancer screening with circulating tumor DNA, etc. Liquid, all this technology that based on genomic technology, sequencing. So this is what we're thinking is the second phase will emphasize more on prevention and will adopt more clinically implemented practice. So we can have what we call precision medicine, and also leveraging on big data and AI, trying to working with other stakeholders like SDAIA and other players. So this is a 3 point I wanted to you. It's going under now as we talk at major transformation, and this is where we're going. It become more clinically oriented, and it will need input from everybody. Genetic counseling is not in isolation. They're involved in the lab, they're involved in the clinics, they're involved in the prevention program, they're involving us in the cancer programs. They're also working with us even virtually using some platforms. With this, I will end. I thank everyone. I'm really sorry if I did not mention any names because I don't want to miss anybody. And thank you again for this opportunity.
Thank you, Dr. Malak, for the informative presentation. Next, we have the topic of prenatal genetic counseling given by Ms. Kira. Ms. Kira Dineen is a licensed certified prenatal genetic counselor at Maternal Fetal Care. She also has 10 years of online media experience in digital marketing, including 5 podcasts. Her main show, DNA Today, won the Best 2020 Science and Medicine Podcast Award. You can listen to her show on their website or Apple, Spotify, or your favorite podcasting app. Kira is also the host of Phenotips Speaker Series. It's a live webinar interviewing genetic leaders. Her blog series called Explained by a Genetic Counselor explores new genetic concepts every month. She was selected and served as a member of the National Society of Genetic Counselors Digital Ambassador Program. She received her Diagnostic Genetic Bachelor's of Science degree at the University of Connecticut and a certified cytogenetic technologist. Kira also received her Master's of Science in Human Genetics at Sarah Lawrence College in New York and is a licensed certified genetic counselor. Welcome, Ms. Kira. Please start your topic.
Great, thank you so much. Appreciate having the invite for this presentation and that intro. As it was just mentioned, I am a genetic counselor practicing in the US, based right outside of New York City. And I'm also the host of DNA Today, which is a podcast. So if you enjoy the topics being covered in today's webinar, certainly feel free to check out the show. So I thought I could start out talking about the screening aspect of prenatal genetic counseling and then talking about the diagnostic procedures and testing. So going through that in terms of the prenatal perspective. So the first is carrier screening. So as kind of mentioned in the previous talk, carrier screening is ideally done before pregnancy. So in these cases, we're hopefully able to identify people that are a carrier of a condition and see if their partner is also a carrier of that same condition. Most of these conditions are inherited in an autosomal recessive pattern, where we see that we all have 2 copies of most of our genes. If one of those copies does not work, we are considered a carrier for this condition. And we can pass that on if our partner is also a carrier for that same condition. That's where a child would inherit 2 non-working copies of that gene, and therefore they don't have a working copy of the gene and have the condition associated. So some of the conditions included on this are cystic fibrosis, Fragile X syndrome, spinal muscular atrophy, and sickle cell disease. The carrier screening really differs depending on how many conditions are being ordered. There's a wide variety of this. Some providers are focused on a handful of genes, 1 gene, and some providers are ordering very large panels with over 500 conditions. So it's important to see, if you're a healthcare provider, to see, okay, not just that your patient had carrier screening, but how many conditions were they tested for? And are those conditions in alignment with their partner? Were they tested for the same conditions? In my practice, I tend to start with the pregnant person and do testing on them. If they come back as a carrier, then testing the paternal sample, so their partner, to see if he is a carrier for that same condition, or in cases of a sperm donor, different situations, seeing that the maternal and paternal samples, that they're not a carrier for the same condition. And if that was the case, then obviously sitting through with them and explaining the risks associated and future testing, which I'll talk about as well. It's important with carrier screening to also take into account where someone's ancestors are from. So what countries. This can give information, particularly in that time period between having the pregnant person's results coming back while we're waiting for their partner's testing. So if that pregnant person has genetic testing with this carrier screening that identifies them as a carrier for a condition, and we're waiting possibly a few days, couple weeks to get results for their partner, we can say, well, instead of giving them a risk that's generic to anybody in the world, we can give a more personalized risk, saying, knowing that your ancestors are from certain countries, we can say the risk of this person being a carrier for the condition is 1 in something. Usually it's 1 in a few hundred. And so this can give us a more specialized number while we wait. This can also provide information if a paternal sample is not available for different reasons. So if we don't have that paternal sample and we find that the pregnant person is a carrier for a condition, this can give us a much more specific number for the pregnancy if we know the paternal side's ancestry. So that's one of the reasons we're looking at that. Through family history, not only are we asking about ancestry, but we're asking about a lot of information. So when I'm taking a family history, I'm constructing a pedigree. So 3 generations is standard in genetic counseling and in genetics, where we have either the pregnancy is that first generation or siblings, depending on what specialty you're in. For prenatal, pregnancy is going to be my first. Then you have the parents and the grandparents. Sometimes great-grandparents may be included if that's brought up during a session. Some of the questions I'm asking during this part of the family history is going through family members specifically. So asking about, the patient's siblings, their parents, their partner's siblings, their parents. And then I tend to ask overarching questions about the family in general. So I say, think about your aunts, uncles, cousins, grandparents, anybody else in the family, not necessarily cousins that are removed from the family, so second cousins, but thinking about these family members as I go through questions. Some of these questions include intellectual disability and autism, birth defects, so looking at if anybody in the family has a hole in their heart, was born with a hole in their heart, they have a cleft lip or palate, extra fingers or toes, so any birth defects. Specific genetic disorders, if the patients are aware of having, say, someone with cystic fibrosis in the family, that's really valuable information to know, well, if they have a family member with cystic fibrosis, depending on that degree of relation, what's their risk of being a carrier if they haven't had that testing yet, or while we're waiting for testing. If anybody in the family has experienced stillbirth, infant death, 2 or more miscarriages, infertility, anybody experiencing early menopause, this can be a sign of people that are carriers of Fragile X syndrome. So that's one of the reasons why I'm focused on that. As I mentioned before, ancestry. So I specifically focus on Jewish ancestry based on where I work. I have a lot of patients that are of an Ashkenazi Jewish background, and they have an increased risk compared to the general population of being carriers for certain conditions. Also looking at cancer in the family. So again, I practice in prenatal, but I am sitting down with them, I'm taking a family history, I'm going to include cancer as part of that because I want to make sure if there is an elevated risk for cancer, if there are factors that point to possibly inherited forms of cancer where we have a mutation, say the earlier presentation mentioned BRCA mutations, Li-Fraumeni syndrome. So I'm taking a look at that as well, because if that does seem to come up, I can refer them to a cancer genetic counselor, which for me is right down the road, which is really convenient. So some of the questions and aspects I'm looking at for this is if anybody in the family has had cancer under the age of 50, so an early onset of cancer, anybody that's had multiple primary cancers, say they've had breast cancer and ovarian cancer, if cancers in the family seem to be linked. So if there are cancers, if we're going with this BRCA example, are there cancers where there's breast cancer, ovarian, prostate, all in the same branch of the family, where I start thinking about what could be a genetic mutation behind this. So all those aspects being considered with cancer. Also asking if there's anybody that's deaf or blind from an early age in the family, if there's any consanguinity in the family of biological relations between partners, that being important, that if they are a carrier of the same condition, that's more likely in cases of consanguinity. If anybody has experienced seizures in the family, and then blood and immune conditions to be aware of, because some of those are genetic. So something like the thalassemias or sickle cell. So, looking at this example here of a pedigree I created, we have the pregnancy here, and looking at this pregnant person here has 3 children, and this would be an example of an autosomal recessive inheritance pattern. So this person has a brother with this disorder, could be, any of the autosomal recessive conditions, could use cystic fibrosis as an example. And we see that their daughter has also been diagnosed with this disorder. So in this case, I am thinking the parents are a carrier of this condition. All evidence points to that. The siblings of the affected child here are also at risk for being carriers of this condition. There would be a 2/3 risk for this. And the partner, the father here, I would recommend for him to talk to his sister, because we see she doesn't have any children, but maybe she is thinking about that or planning on that. So she should be aware, if she isn't already, about this condition in the family. Another aspect of screening when it comes to prenatal is looking at maternal age. So how old someone is at birth, so at delivery. So this does increase over time. I explain it to patients as eggs having a harder time counting chromosomes as we get older. So it's more likely to miscount a chromosome and have an extra chromosome, such as trisomy 13, 18, 21, so Down syndrome there. The top of the graph here is 12.5%, certainly not 100%, but we do see it around 35, this really starts to increase. So I review this with patients and give that information for them so that they're aware of that risk before they start doing testing. In terms of other aspects of prenatal care, looking at ultrasounds, I'm going to focus in on the nuchal translucency ultrasound that's usually performed between 12 and 14 weeks. In our office, we really try to do this at 13 weeks. And so when it comes to the nuchal translucency ultrasound, we're looking at two specific pieces of information coming from this genetics perspective. The first is looking at the back of the neck measurement. So that's the NT measurement. To see how much fluid is there. A little bit of fluid is natural. That's what we expect to see. If that measurement is larger, there's excess fluid there, that could be a sign of a genetic condition, and that's considered an abnormal number. If that's above 3.0, 3.5, that's when it has a higher risk for chromosome abnormality associated with that. And the more fluid that is present, once it's over that 3.0 measurement, the higher the chance is for chromosome abnormality. And what that could mean is obviously genetic syndromes that I've mentioned, such as Down syndrome, could also be a sign of cardiac structural anomalies and developmental delay. In cases where we do have this high NT measurement of that excess fluid at the back of the neck, next steps may be doing blood testing, so cell-free DNA, also known as non-invasive prenatal screening, which I'll review. Possibly doing invasive testing, so a CVS, chorionic villus sampling, or amniocentesis to test for conditions. Most people also are doing an early anatomy ultrasound. So that's at 20 weeks where we're looking halfway through the pregnancy to check in on multitude of aspects for the fetus. And also looking at a fetal-echocardiogram. So focusing in on the baby's heart to see again, because there is that correlation with structural heart defects. So taking a closer look at usually 22 weeks is the ideal time period for that to see any problems with the heart that we can identify at that point. In terms of the non-invasive prenatal screening, this is a major aspect of my job as a prenatal genetic counselor. So, so kind of going back here to this slide that reviews the basics of this, the generic name for this is cell-free DNA testing. And how this works is there are cells naturally coming off of a pregnant person's placenta and floating in their bloodstream. Those cells tend to pop open and release their DNA. So when a blood sample is taken, we can look at this cell-free DNA and focus in on the fetal DNA. This can be performed, the earliest that I have seen in terms of what labs offer is 9 weeks gestation. Most companies are usually 10 weeks gestation, so around there. And after that, at any point in pregnancy, if we are drawing the sample at 39 weeks, we may have results after the baby is born, but that theoretically could be done. So for this testing, we are looking at mainly extra missing chromosome disorders. So as I mentioned, trisomy 13, 18, trisomy 21 being Down syndrome, usually looking at the sex chromosomes as well. So some patients know of this as the test that reveals the sex of the baby. And some of the other conditions that can be included are microdeletion syndrome, such as DiGeorge syndrome. The detection rate isn't as high for those disorders, kind of as a blanket statement for most of the labs. And when I'm reviewing this with patients, I also mentioned that we could find out something about the pregnant person's health information. So it's possible if that pregnant person has a genetic disorder, that could come up with testing, or if they possibly have cancer and we have cancer cells with this cell-free DNA that's skewing results and, being alerted to us through this testing. So I mention that in case patients don't want that information and would rather skip the testing. Results, again, I work in the US, but results tend to come back about 7 to 10 days. So in about a week, I typically have results. And in terms of the two types of non-invasive prenatal screening, most labs are performing this testing through massively parallel sequencing method. So with this method, we're looking at all the cell-free DNA. So that's going to be from the maternal sample, from the pregnant person, and from the placenta. So this is labeled as the fetal, but if we're getting technical, it's coming from the placenta. So all of that is sequenced, and the way that we're analyzing this is looking at the ratio. So we're looking at the ratio between the maternal cell-free DNA and the fetal cell-free DNA. And if we see that there's extra, say, using Down Down syndrome as an example, extra chromosome 21 material, we start to question, okay, if there's extra chromosome 21 material being identified, there's a higher risk for this pregnancy to be affected by Down syndrome. So it's a ratio base there. The other type of testing for this non-invasive prenatal screening is SNP-based, so single nucleotide polymorphism. So instead of a ratio based of looking at how much fetal cell-free DNA there is compared to the maternal, we're looking at specific spelling changes in the genetic code. So we're able to figure out what cell line is the mother's and what cell line is the pregnancies or the fetus. And so we're looking at specific points that are going to differ because the pregnant person and the fetus is going to have different genetics. They're not going to be identical. So it's really that paternal sample that's providing those other SNPs, those other spelling differences in the genetic code for us to be able to figure that out. So those are the main two approaches with that. Switching over now to the second part here, I know I am kind of close to time. The diagnostic procedures and tests for this, amniocentesis is where we take a little bit of the amniotic fluid and test for that. The baby is releasing skin cells, just as we're sitting here, we're shedding skin cells, baby does the same thing. So by taking a little bit of amniotic fluid, we can test those cells. And for this, we are getting an answer, diagnostic answer. So does the baby have this condition or not have this condition? Compared to blood tests where we're saying, is there a high risk or a low risk for these conditions? So that's really the main difference between the screening tests and the diagnostic tests. And the other type of diagnostic test here is the CVS, chorionic villus sampling, where instead of the amniotic fluid, we're taking a little piece of the placenta there. The types of results we can get from this, typically the first result to come back is the fluorescent in situ hybridization, so FISH. We're doing a quick highlight on the chromosomes to get a number. How many chromosomes, 13, 18, 21, and sex chromosomes are there? So if we're continuing our Down syndrome example, here we're seeing that there are 3 copies of the chromosome 21. So this is giving us an initial result of Down syndrome, which can then be confirmed with a karyotype where we're actually looking at the chromosomes, we're counting them, we're doing band for band analysis. So looking, are there any extra chunks or missing chunks there? The other type of test that can come out of this is a microarray. This is getting even more detailed in terms of if there are extra or missing pieces of DNA that are too small to see on a karyotype. So with that, I want to thank everybody for your attention. It was lovely to be able to present to all of you. If you want to connect with me and my podcast, you can check us out on Twitter at DNA Podcast, Instagram at DNA Radio. And if you want to directly reach out, email is info@dnapodcast.com. And again, the podcast is available on all major podcasting platforms. So thank you so much for your attention today and hope you enjoy the rest of it.
Thank you, Ms. Kira, for your presentation. It was very informative. If anybody has any questions to the speakers in the first session, please feel free to type the questions in the Q&A. You could see it on your screen down. And Dr. Ahmed has a question, MCQ, multiple choice question for the attendees. If you would like to participate in solving this question, question is, what is the most common disorder in Saudi Arabia? Please choose what choice you think is the most correct. And if anybody has any other questions. Okay. Ms. Nadine, if you can put the solution on. Okay, so most of you, 73% answered autosomal recessive, which is the correct answer. Now to the questions. I'm gonna read the questions to the speakers. Dr. Ahmed, you have a question from Sabha Rabia. She says, regarding the Brugada syndrome, what's the reason behind this wide interval of age of onset? Are there other factors that contribute to the age of onset?
So, well, thank you so much for this important question. Usually, the autosomal dominant disorders in general, like Brugada syndrome, have many other contributing factors, and one of them we called it either penetrance or expressivity. And the disease, how the disease is expressed, it's a part of the features of autosomal dominant, and it could in the father and a child, and both of them will have different manifestations or the wide range. We don't know really why. We think there might be an environmental triggers or factors could contribute to these differences in the presentations in general of autosomal dominant disease, and one of them is the Brugada syndrome. That's it.
Okay, thank you, Dr. Ahmed. Dr. Malak, you have 3 questions as well. The first question is, how are we going to utilize the data of the Saudi genome in designing gene panels that are customized to the most common pathogenic variants in our community? Also, from my simple experience with premarital screening, alpha thalassemia is very important to consider into the program as well. Thank you.
Thank you, Lama, and thank you for the question. As I maybe I was quick. Actually, this is how it was used in the first phase. There was some customized gene panels. This is the way how it started this project, based on the common genes, common variant in Saudis. And it will be more, you will see it more in the next phase because it will be more in clinical use. So yes, we use this database to generate, to customize gene panels for different reasons. It's quicker to analyze them, they're faster, they're cheaper, and they are implementable. The same what happened with the premarital screening program, the expanding new one, which also based was customized SHIP, included all variant that common in Saudi. I also, I see two other question, if you allow me, from Dr. Arish Hariri.
Yes, please, doctor, go ahead.
Yeah, just to save your time. She asked about the familial cancer project. Yes, it's not published yet. We're gonna present the abstract in the American Society of Human Genetics. It was accepted, and it will be presented, and it, inshallah, and if everything went well, it will be available by the end of the year. And meanwhile, I recommend you to read a review written by 3 genetic counselor star by Fawz Al-Harsi, Ala Idris, Ali Agari. They wrote it about familial cancer in Arab world. It's published in MPJ Genomic Medicine until the study come out. I also see somebody asking how we can get the Saudi genome data. Well, it used to be, it's open in the website. You can register and submit your proposal. But for now, I just want everybody to be patient with us. It's going under a major transformation. Everything in King Abdul City for Science and Technology, including Saudi Genome. We have new leadership, new director for the centers, Dr. Batul Al-Baz, etc. So if you just bear with us until the end of the year, we'll announce all the new changes and how. And this is the goal. We want everybody to be involved and work on this and this data, the existing one or the new one, which will be generated. Thank you.
Okay, Dr. Malak, there's also another question that says, how much do you use genomics technologies like sequencing, single cell analysis versus commercial genetics tests in your regular clinical practice? And do you use bioinformatics or data science techniques to further explore your patient's data? Question to Dr. Ahmed and Dr. Malak.
Please start, Dr. Ahmed.
Maybe Dr. Ahmed lost connection. Ms. Kira?
Yeah, I will tell you from my experience working in the clinical labs, we're not 100% using national lab at this point for especially next generation sequencing. So we're depending a lot about some labs outside the kingdom. Saudi Genome, most of its applications almost in the phase 1 is research based. So We did not really use a lot of it in the clinic, except some experimental part was done with the Saudi Diagnostic Lab at King Faisal sometime. So we use bioinformatics. Yes, we have our own our pipeline that been built by the bioinformatics team, but we use some. We're planning to use some other existing platform with different companies. It's a matter about how to have everything in the kingdom secured. We're really not using cloud system at this point. Everything has to be servers inside the kingdom. What else? Another question come. Do you?
A lot of questions, Doctor.
I know.
In
I
regards
got
to the
lost.
access.
Wallah. I got lost.
Yes.
I got on the question. I told
yeah.
you, just bear with us, please.
So,
Genome 2.0 coming, and you have access to everyone. Please go ahead, Dr. Ahmed. Help me.
Thank you so much. Well, I can share with you something also. Well, to answer the question from Dr. Huda, we do exome in our facility at King Abdulaziz Medical City at the National Guard, and we do local exome. Almost now we reached to 80 to 60%. We do also genome. Regarding the access to the database, also I can share with you. We opened our database at the KMark, and it's almost represent the genomic database that we have been collecting for the last 5 years, and it's merely a clinical genomic database that will be very useful for any diagnostic lab. I will share the link with anyone who is interested in the chat, and if you want to register, just send me an email. You need to create an account, register yourself, send me an email. We will activate your account. Then you will have access to exome and genome data from the Saudi population. It will not replace the Saudi human genome for sure, and it's more of a clinical data for analysis. At single sample, not at the high, it's not like for large research.
Okay, thank you, Dr. Ahmed. Ms. Kira, there's a question to you about how is the fetus DNA distinguished or differentiated from the maternal DNA?
So from the best of my knowledge, there's two aspects of this. The first is that fetal DNA, the cell-free fetal DNA, tends to have smaller sizes compared to maternal cell-free DNA. So that's an aspect that the lab uses in order to do that. So some labs do that in order to amplify the DNA. So the other part of that is they're looking at the fraction. So they're looking at what is the fetal fraction, what % of the DNA is actually coming off the placenta. And so that can help as well, because you're going to have mostly maternal cell-free DNA compared to fetal cell DNA. So kind of those are the two aspects that are taken into account. I'm sure someone that works directly in the lab could probably give you a more robust answer to that. But to the best of my knowledge, those are the two aspects that they use.
Thank you, Ms. Kira. Dr. Ahmed, why are the most common genetic disorders in Saudi Arabia not tested in the premarital examination, for example, G6PD and congenital adrenal hyperplasia?
So there are many reasons. The major, most important factor is the technology itself. There are some limitations for the technology that we will not be able to do a large population at a large scale, all the population. And this is all sometimes the cost. For example, now to test for newborn screening, it's costing around 100 riyal. And to do the premarital testing for the sickle cell or thalassemia, it's costing around 10 to 15 riyals per patient. But to do for congenital adrenal hyperplasia or G6PD or etc., it costs a lot more. The G6PD is now, some hospitals are including it in the newborn screening, but not in the premarital screening. Two is the ethical, social issue is if we find someone who are a carrier, there is no clinic to refer them to. How would you deal? It's not just appropriate to say you're a carrier what's your risk. We needed counselors, and there are not enough counselors in the country to handle and deal with all these issues.
Yes, totally agreed. Okay, another question is, can whole exome sequencing tests for premarital screening prevent autosomal recessive diseases?
We do selectively in our institution, couples who are, if they are, for example, our first cousin, and then they want to do a whole exome sequencing before getting married, or if they are married and they, yes, we do, and we can identify if they are a carrier or no. But then the options, how to explain these results, what are their options, either PGTA or IVF or amniocentesis during pregnancy, and these all things. It's not only the testing itself. The testing is the easiest part. Is the post testing and the counseling is the most difficult part.
Yes. Another question is, what's the turnaround time for the whole exome in Saudi Arabia? And do we have clinical exome special designed for Saudis? I think Dr. Malak is going to answer this question.
Turnaround time, it depends. I mean, some labs, they start with, they call it flash or quick exams. They can report results within 72 hours in case of emergencies. Usual turnaround time, at least when I was working as a medical director full-time, between 4 to 6 weeks. Now, some labs can do it at much faster than this, and some can take more time. It depends about the load and what is the capacity, high throughput of the lab. Send out, I mean, I'm not working with the send out for the last 3 years, so maybe Dr. Ahmed can tell us more what is his experience.
So thank you, Dr. Malak. We do exome, and our average around time for exome in the local is 15 to 20 days if it is routinely and no issues. We do rapid whole genome, where we can get the result in 3 days for sick babies. But the routine, if you do it locally, the routine, I would say 20 to 30 days will be more than enough. Send out is 30 days, 6 weeks. Depend which lab you are dealing with.
Okay, thank you, Dr. Ahmed. Thank you, Dr. Malak. I think we are done with the questions. Just to make sure. Okay, there's just one last question. What's the criteria of sample collection for the Saudi Genome Project?
So as I mentioned quickly, each satellite site have certain projects. They get their IRP approval, ethical approval, and they can recruit under these projects. So CACs don't really go in these details. It leaves it to each institution, depend on which project they're working on. They can recruit patients. And for the CAC, Central Laboratories and Ministry of Health, they're working now in premarital screening, and it has a criteria. It's now still a research project, but a genetic counselor and clinical educator try to explain to the newly couple if they want to be part of the study. So it's totally voluntary to be recruited or not.
Thank you, doctors. Thank you for all the questions, and thank you to the
Do you
speakers.
mind
We're
just
gonna
one
start-
second?
Yes,
There are
sure.
too many people asking me about the links. So for the database, if you can just share it in the
Sure,
chat.
please. Yes, okay. You can share it
Do you
with us.
have
We'll
it
type
now?
it in. I'll take it from the private chat and put it into the questions.
Okay.
Okay, thank you. We have a 10-minute break then to our next session with the other topics. Thank you, everybody.
كود شافوا الاشياء دي لا ما اديتهمش كود في الاخر ما كود قصدي يعني هم قالوا بيشوفونها
Hello, everybody, and welcome back after the break. We're going to start the second session now. The second session has 3 topics. The first topic is going to be ethical issues in genetic counseling. It's going to be given by Dr. Khadija Bakr. Dr. Khadija Bakr is a genetic counselor with more than 10 years of experience. She has her master's and PhD degrees in genetic counseling from the University of Manchester in the UK. She chairs the Clinical Affairs Committee at the Department of Genetic Medicine at Princess Johara Center of Excellence in Research and Hereditary Disorders at King Abdulaziz University. She's a member of the Ethics Committee at the Princess Johara Center. Alongside her clinical duties, Dr. Khadija is a lecturer in the King Abdulaziz University Master of Genetics Counseling Program. Her main areas of interests are ethics, communication in healthcare, and genetic counseling process, developmental of community genetic counseling services, and genetic counseling in multicultural settings. She has been invited to give lectures in a number of international Master of Genetic Counseling programs, with the latest at the University of Siena in Italy. Welcome, Dr. Khadija, to the talk, and please start your topic.
Hello? I'm not able to share the slide.
Dr. Khadija, if you put share screen, the green button down with the arrow up, yes.
Thanks for the organizing committee for inviting me to speak about ethical issues in genetic counseling for today's webinar. I want to highlight an important point before I start. Although I'll touch base generally on ethical issues in the context of genetic counseling, I do not intend to go into many details. My aim from this presentation is to give an overview of the importance of having a systematic pathway and approach in dealing with ethical dilemmas in clinical setting. As an example, I'll be presenting a brief of a framework that I personally developed to help me in navigating such cases. It is important to let you know that this work is not yet published and still under review. The term bioethics was officially coined in 1926. However, the idea of medical ethics arose long before that date, going back to the ancient Greek. What is known today as bioethics has undergone a complex conceptual transmogrification. Bioethics draws on multiple disciplines such as medicine, law, religion, economy, political science, and psychology. It aims to value the patient, the profession, and the society with a major aim to do no harm. The four main ethical principles are autonomy, which means that all persons are autonomous beings and have a fundamental right to self-determination. In healthcare, autonomy means all patients are competent to self-determining decision makers. They have the right to accept or decline any healthcare intervention. It is vital to pay attention to the competency of the patient, as in your clinic, you could see a patient who is mentally challenged or a minor without the capacity to make his or her own decision. Either cases calls for a substitute decision making. Beneficence means that everyone has a duty to advance the good of others if it is possible to do so without undue risk to oneself. Non-maleficence. Hello? Hello, could you hear me?
Yes, we hear you, Dr. Khadija. You can continue.
Yeah, sorry. طيب السلايدز ما أعرف إيش صار فيها. Sorry. Non-maleficence means that everyone has a duty to prevent harm to others. It is important to know what counts as good and harm, as it is always subjective and relative to the individual's values, the patient's values, and not always to the health professional's value, nor anyone else. Justice generally refers to everyone having an equal opportunity. We seek to eliminate discrimination in healthcare. It should not be based on sex, race, religious beliefs, or any other criteria. Observing these principles is important, as doing so aids healthcare providers and give them an approach in making a medical decision reflecting moral issues that arise in the workplace, ensuring decisions that are ethically sound and align well with the patient values, preferences, and promote a good quality of life. However, the complexity in medical ethics comes from the fact that it is case dependent. There is not always a right or wrong decision. When an ethical dilemma or ethical issue arises in clinical practice, we should pay attention to many factors, and the decision could differ in different cases. The field of genetic counseling poses more challenges when it comes to ethical dilemma for many reasons. Among them is the fact that genetic counseling is a family-oriented practice. We don't really deal with patients only, because the diagnosis or the test result in many cases doesn't only concern the patient, it has implication for the wider family. Another reason is the lack of treatment in many cases. The burden of knowledge makes genetic counseling ethically challenging. It is in the nature of the practice that we as genetic professionals, we sometimes come to know several generations and branches of at-risk family members. In other words, what I want to say is that it is not rare for the practitioner to know more about the family than the patient in front of them. This orientation toward the family can sometimes lead to situations in which recording and remembering the familial information produce problems and challenges. As you can see here, ethical dilemmas in genetic counseling practice could arise by different avenues, such as, for example, a questionable genetic counseling guiding concept and a well-debated concept like non-directiveness. Argument against non-directiveness include, but not limited to, the fact that it is not particularly attainable, as much have you experienced. It also limits a counselor engagement with the patient. In many cases, it hinders counselors discussing evidence-based medical recommendations. Genetic counseling at its best is defined as facilitating. In terms of empowering the patient to make an informed decision, depending on the particular situation, the counselor must adopt a more balanced, client-centered communication and make appropriate advice-based medical recommendation. Of course, we don't mean to eliminate the right of the patient to make decisions, nor to bias it, but rather to attend to the patient's specific needs. Empirical data showed that many women prefer clear recommendation about which prenatal genome sequencing result to receive, and the burden of responsibility they feel about prenatal decision-making can be alleviated and relieved by positive affirmation from the counselor. Adding to the general avenues by which ethical issues could arise, population-specific factors in Saudi Arabia could also contribute to increasingly encountering ethical dilemmas in genetic counseling practice. Among those are cultural norms, religion, the family structure, the limited number of genetic professionals, the lack of enough national specific and appropriate guidelines and policies that consider the Saudi context, and the lack of research in the field of genetic counseling. Genetic counseling is a relatively young profession, especially in the Arab region, and indeed, it reflects the profession's Western cultural bias. We should conduct qualitative research to investigate the appropriateness of applying counseling principles, the impact of the family structure, how Saudi patients make sense of their diagnosis, and how they cope in light of our specific cultural norms and religious beliefs. This is vitally important to informing culturally competent counseling. All healthcare professionals are expected to theoretically be familiar with principles of ethics, yet when it comes to practice and application, even the most experienced healthcare professional could face challenges in navigating ethical dilemmas. We should think of what facts of the case are important to know and how we should weigh them, so we feel confident in dealing with the situation and offering a recommendation that is appropriate and ethically sound. Often there are multiple clinical facts to consider. In addition, patient values and preferences and family concerns and values, those are all must be considered. Generally speaking, several widely used practical frameworks, such as the Jason Grid, help healthcare professionals to judge and act upon ethical dilemmas. However, not many are designed to be applied in the context of genetic counseling when one considers practice specifications. As I said, it is acknowledged that medical decision-making is not only difficult for the patient, sometimes it is even challenging for the healthcare professional themselves. In that regard, I developed a framework with the hope that it can help genetic professionals to manage ethical dilemmas in clinical setting. This approach or framework revolves around 9 to 10 domains with several questions in each domain to prompt deep exploration of the case, taking a holistic approach. Of course, this framework will not tell you what to do or what not to do, but if followed systematically, it has the potential to guide and facilitate ethical decision-making. Of course, not all domains apply to all cases, but we anticipate that having this systematic approach or framework will help the healthcare professional to avoid missing an important factor that could have an implication for the decision-making process. One of its advantages is that it is designed to help engage the patient, which I see as an important thing, in the process of navigating the ethical dilemma, prompting him or her to think about important factors that might be of value to them. It helps to resolve the cognitive dissonance the patient experiences, as this framework supports the approach of patient-centered shared decision-making. Sorry, the slides keep freezing. So this is a selection of some of the questions contained in the framework to show how you can use it in clinical setting. The next couple of slides, I'll present one or two cases, depending on how we do for time, and I'll take you through the process of applying the questions from the framework. However, as the aim here is just to show the process of implementation, I'll not present the final decision made. As I said, each case is different, and health professionals could arrive at different decisions, even with the same or similar cases. So this patient came to see me in the clinic as she was struggling to decide on invasive prenatal testing after receiving her NIPT result. Her struggle was not caused by the fear of the procedure or lack of information regarding the procedure. She was struggling as she knows that she could face the challenge to decide on termination of pregnancy. So the main conflict was whether to terminate or not. This conflict has potential impact on different parties on many levels and aspects, and you could list those. The contextual information you would gather using the counseling skills and the systematic approach or framework in many cases have important implication on the decision-making process, and it could change the scene. Apparently, the patient wasn't really ready and wasn't expected to hear this result. She underwent NIPT with the sole aim to know the gender of the baby. She had no clue what this test could reveal. As this was her first pregnancy, she was thrilled to throw a huge, what so-called gender revealing party, a trend that wasn't really liked or preferred by the husband who believes that overexpensing could cause God's punishment. Interestingly enough, she first heard about NIPT from an event planner on Instagram. And yes, you heard me right, the event planner. And this is the society that we live in. The event planner advertised NIPT as the fastest and most accurate way to determine the gender. As the protocols of the gender revealing party, the mother of the patient, who turned to be against termination, went to receive the NIPT result with her daughter. The patient perception regarding Down syndrome is hugely shaped by her experience with her friend who is severely affected, her friend's child who is severely affected. This contextual information is important because you would have a sense of the support system the patient has. You would know the preceding factors that caused the problem. You could also figure out whether the conflict regarding termination is internal or external. The information will also help you to think of what resources are available that you could use in this case. Having the patient on board, you could then go through possible solutions, the actions, plans, weighing pros and cons of each of them, and see how each possible solution score in reference to ethical principles and moral obligations, and how it could also align with patients' quality of life. You might think of maybe bringing the husband and mother on board. You might explore their beliefs and perception regarding termination, or terminating a fetus with Down syndrome, as those are different things. You could work to alternate misbeliefs or conceptions as appropriate. You might have concerns regarding the patient's capacity to make her decision, taking in consideration that she is still in shock as a result of the way she received the news. Maybe she is competent, maybe she needs a bit more of time or a formal psychological support if you felt that this is necessary, or if the patient felt that she would benefit from such support. If she decided to terminate against the wish of her husband, for example, would the local law allow her? Would health practitioners be caught on that? And so on. By then, you and your patient would have reached a decision that is hopefully ethically sound and promotes the patient's sense of well-being and quality of life. As a personal preference and as an act of justice, you would think of the factors that could be causing the problem. You could act on a plan to prevent or minimize the reoccurrence of the same problem to other patients as much as possible. Maybe you could think of upskilling non-genetic health professionals and providing them with the practice resources on how they communicate prenatal and postnatal diagnosis of Down syndrome, as this mostly done by pediatricians and obstetricians. You would think of what other ethical issues you could prevent in the same context, taking in consideration that the American College of Obstetricians and Gynecologists in 2020 published practice bulletin recommending that NIPT to be offered as one of the genetic screening options to all pregnant women, regardless of maternal age or any prior risk of chromosomal aneuploidies. As you would anticipate that the use of NIPT is likely to increase dramatically in the near future, especially in the private sector, we should pay so much attention to the ethical issues that could rise as a result of endorsing such guidelines. In fact, many health professionals link risk of aneuploidies only to advanced maternal age, so they neglect informing young patients regarding their odds of having an affected child when they request an IPT, or they just mention it casually. I know that any well-skilled genetic counselor or geneticist will be able to gather all this information and to go through the ethical dilemma, but having the framework will help you not to miss any important information. And as I said, it will help you to bring the patient on board. I intentionally chose to present this case to remind you that even a simple screening test and not really complicated diagnosis could raise serious ethical dilemma for the patient and could be tricky to solve if not handled with caution. Patient will live long with the consequences of their decisions and might regret many of them if they weren't carefully considered. Having a systematic framework or practical guidance has the potential to increase the quality of analysis and reflection in the field of genetic ethics. I'll just skip the second case as we're almost about to finish. As genetic counselor and clinical geneticist, we encounter ethical challenges almost every day in practice. There are many reasons why we could encounter them. Confidentiality, boundaries, and duty to warn at-risk relatives are among our recurrent problems. Facing disagreement between spouses regarding reproductive options, testing of asymptomatic minors, and weighing the parents' wish and the right of children, duties and obligation in classification review, and reporting of incidental findings, especially of adult onset diseases that revealed when testing a minor, are all situations that we encounter regularly in the clinic. Genetic counselors play many roles that could contribute significantly to minimize ethical dilemma in the clinical setting. As we are hard to reach professionals, we could ensure providing proper service to our patient who could not reach us by doing, and we do them good by upskilling non-genetic health professionals. We also could benefit from assembling ethics interest groups, such as the one running under the umbrella of the National Society of Genetic Counselors, where the aim of this group is not to give specific advices or directives, as none could do that, but rather to provide practitioners with information they can use in connection with developing a plan to handle ethical issues. Of course, I can't emphasize enough the importance of conducting qualitative research as the way to go if we aim toward culturally competent counseling. We have a duty to empower the patient and society, and not only to inform them about the disorder implication or the recurrence risk. The ultimate goal of genetic counseling is about empowering patients, preparing them, and making them competent to make an informed decision, especially in the recent era of next generation sequencing and precision medicine, where we anticipate that many ethical issues will arise as this advancement continue to grow. I would like to end my presentation with this slide. We should ask ourselves if we are ready for this era, and what effort we should put forth to make us and the society ready to face that challenge. In my opinion, we should consciously observe how we practice, as we are prone to counterintuitively deal with patients as variants and data. On the contrary, I like to coin genetic counseling as humanizing the variant rather than digitizing the patient. And thank you.
Thank you very much, Dr. Khadija. Very, very, very enjoyable presentation, and it hits close to the heart. Thank you for this topic.
You're welcome.
Our second topic will be the approach to genomic counseling in precision medicine. This talk will be given by Ms. Lamia Sberi. Ms. Lamia Sberi is a senior licensed genetic counselor at National Guard Health Affairs with experience in clinical laboratory and research settings. Lamia is also a board member of the Arab Association of Genetic Counselors and Saudi chapter chair at Live for Mene syndrome. Association and a member of the Genetic Counseling Advisory Group. In 2016, she was assigned, along with her current role, to open the first high-risk clinic in hereditary cancer in the oncology department at King Abdullah Specialized Children's Hospital. And in 2017, Ms. Lamia was part of a 5-person expert team that established the next generation sequencing core facility in the Translational Pathology Lab. In addition, she worked as a research genetic counselor to help establish the 1000 Saudi Familial Cancer Genome Initiative at the Saudi Human Genome Project Satellite Lab at King Fahd Medical City from April 2017 to July 2018. And since 2018, Lamia has been an examiner for genetic and genetic counseling licensor at the Saudi Commission of Health Specialties. Ms. Lamia was also awarded a scholarship to study in North America, so she became the first Saudi graduate with the master's degree in human genetics, genetic counseling from Sarah Lawrence College in New York. Currently, Lamia is pursuing her PhD in medical genetics with her passion for research in genetics. Lamia has authored and co-authored more than 20 papers in the field and committed to multiple future research projects, primarily in cancer and population genetics. Hello, Ms. Lamia. Please start with your topic.
Lama, thank you so much. Can you see my slide now? Hello?
Yes, dear, you can start.
Okay, perfect. Assalamu alaikum jami'an. I would like to thank you all for being with us tonight. My name is Lamia Spey, and I'm presenting the approach of genomic counseling in precision medicine. You've probably heard of precision, personalized, or even the word P for medicine. Precision medicine basically is an approach toward prevention, diagnosis, and treatment of diseases that takes into account variability in genes, environment, and lifestyles for each individual. On a larger scale, population health can be improved by uncovering and addressing genetic risk factors for disease with precision medicine approach or method. And this will reduce the cost, resources, especially when knowledge gained feeds back into the healthcare system in general. It is sometimes misinterpreted as implying that unique treatment can be designed for each individual based on testing results, like, for example, tumor markers, for example. But honestly, it doesn't really mean the creation of a drug or a technique that are unique to a patient. But it gives us the ability to classify individuals into subpopulations that differ in their subspecialty to a particular disease or their responses to a specific treatment based on their genetic variation. For this reason, precision medicine is preferable to personalized medicine. So no one usually calls it personalized medicine. And it is apparent that genetic testing is a pillar of precision medicine, especially genomic sequencing. Genetic testing means genetic counselors. While genetic counselors originally supported their families with definitive diagnosis, today genetic, or what we call genomic counselors, are increasingly using a precise genetic information to assess a risk, support a decision-making process about not only rare and monogenic disease, but also common disease. The relative interest in personalized medicine in red was significant since ever. However, the broader and very accurate term precision medicine in blue came to service since the Precision Medicine Initiative started in 2015, as per the publication on the left side of the slide. Here is a sample of conditions on genetic home reference to which precision medicine could be applied. The first one is precision oncology. Genomic profiling is done on somatic and germline cells from patients to determine certain diagnoses, targeted treatment, or stages of cancer in patient, or defining hereditary cancer syndromes like Li-Fermini syndrome, for example. The second group of conditions are the immune system disorders that include rheumatoid arthritis and SLE. The third group include enzyme deficiency, which goes under, mostly goes under metabolic disease, like familial hypercholesteremia, The third or the last one of the condition that the genetic condition that goes into or define the precision medicine is the pharmacogenetic, to identify the adverse drug reaction, like in warfarin, malignant hyperthermia. And this is basically done to help select a type and dose of medication to treat a specific disease. For example, a term of researcher that suggested that precision oncology in specific may improve the overall survival for refractory cancer patients, while lowering the average per week healthcare cost, resources utilization, and even end-of-life cost. Another example is a drug listed on FDA list for which the data available for us is supporting the therapeutic management recommendations. This list has been updated just recently this year, 2021. Please note that there is a higher adverse reaction risk, severe and life-threatening, or even fatal toxicity associated with variants identified in DPYD gene. All of the practice of precision medicine goes under genetic counselor's scope of practice, discussing in one genetic result, and incorporating a medical and family history, and even providing an individualized risk assessment. Actually, genetic counseling considered the very first form of precision medicine. And now there is a huge debate about what genomic counseling will include and who will practice it. The framework of genetic counselors that was codified nearly 50 years ago in 1969 has matured with the advancement of technology and the increasing the availability of empirical data. The key changes that will impact the transition from genetic to genomic counseling include these 3 points. The first one is the increasing number of conditions revealed in testing. Secondly, increasing the number of positive and most importantly, an uncertain result, and the variety of disclosed results, incidental, predictive, carrier result. This brings to attention how to deal with the clinical validity and utility of genomic results also. Not only dealing with these results as a matter of fact, but we have to investigate the validity and utility of each test result that are provided to us, either by the patient or the physicians. The last one is, and most importantly, the time spent with the patient, because we are moving from a diagnosis-focused approach toward a preventive approach that covers many conditions. Competency and available tools and resources are considered the more important assets for genomic counselors. Competency-based practice is defined by 3 pillars: knowledge, skills, and abilities. For instance, the term knowledge. Genetic counselors will need to become more literate in areas referred as omics, including genomics, epigenomics, proteomics, and metabolomics, regardless of whether they specialize or become a generalist. There are many types of competency, like professional competency, cultural competency, and others. For practice-based competencies for genetic counselors, these are the 4 domains listed here. From my observation, honestly, as an examiner for the Saudi Commission for Health Specialists, there is a huge need for improving the competency of the profession here in Saudi Arabia and everywhere. For instance, I have asked one question that goes under the 4th domain that almost answered wrongly all the time. I remember only one candidate that scored this question. The question was asking about ethical, legal principles and the policies of local institution and organization. Maybe we know about the international guidelines, but we are not fully aware of the local institution and organization of Sharia and laws and how we to deal with our patient. I will add to this cases that was mentioned by Dr. Khadija. People come to our clinic with their legal guardians. When I ask the counselors and my colleagues, who is your patient and how you will deal with it, I find the struggle with what to deal and how to define the best approach for those patients, especially if the legal guardian is practicing the rule of decision-making in the case. Not only competency, but also the number of professionals available is a challenge. In our paper on the global state of genetic counseling profession that was published with an international effort, Almost 70% of the listed countries who have established genetic counselors have less than 5 counselors per 1 million population. However, in Saudi Arabia, we have 1 counselor per nearly 8 million population. So this is another challenge. Having few professionals doesn't mean that the service is not needed, but maybe in most of the times covered by doctors and nurses here in the country. We anticipated to face a huge demand to the service as millions of individuals are or will be sequenced in the next few years, honestly, and especially with the project going, an initiative that going in National Guard Health Affairs or the on a national scales even. So it is clear that genetic counselors will need to play a significant role in spreading the precision health effort forward from research and health system initiative to population sequencing initiative to even direct to consumer genetic testing. This is a study by Sweet and his colleagues as part of Korean Personalized Medicine Collaborative Study among individuals who were interviewed about their experience with genetic counseling, either in person on the left side of the chart or by phone on the right side. The majority reported a positive impression and were willing to access genetic counseling services in the future if additional results were returned. So there is a need, but we have to keep in mind that time spent on patients in providing genetic counseling, not genomic counseling, since there is no available data for genomic counseling. So the combined time the GC is spent is about 7 hours per new patient and 3.5 hours per returning patient. This is as per the professional status survey. The award of the most consuming task goes to PRA, which is 50 to 60% of the time. Patient-related activities, including case preparation, risk assessment, follow-up, and personally, I think this time will be increased, especially if we are dealing with more than one variant and more than one risk possibility to communicate with the family. So how we get ready for genomic counseling and genomic precision medicine in general? The answer is AI, honestly, and machine learning. The FDA approved list for AI and machine learning recognized using a technology to improve healthcare and genomics. Here, I want you to meet Gia from the US and Rosa from Norway, our genetic counseling assistant. A paper published a few months ago discussed the effectiveness of chatbots. So those 2 assistants are chatbots that use AI to communicate with the patient in genetic counseling session in particular. So especially in the tasks that are repetitive and scriptable, and like obtaining a consent form, triaging against the medical and referral guidelines, and even family history intake and follow-up, especially for patients who received a VUS result and need a follow-up in a period of 1 year. 92% of all those who used the chatbot described it as effective way to get information, in opposed to 8% who preferred in-person or phone call with a genetic counselor. Here is probably let me ask you this question. Machine learning is a subset of artificial intelligence, right? In which algorithm learn from the data provided to it. So is there available fully structured genomic database to apply AI? I mean, we have a lot of publicly available databases, but are they really useful for AI, for artificial intelligence? This question in specific provoked our initiative in National Guard Health Affairs with a team leading by Dr. Ahmed Al-Faris for a clinically curated genomic database, which is now publicly available under the name KGD, KMark Genomic Database. Up to our knowledge, this is the only database that provides phenotype associated with a variant, with each variant. That's why Dr. Ahmed referred to it as a clinical database and a clinically curated database. And I think our colleagues will post the link for this database in the next, after the presentation. With this database, we were able to reassign the pathogenicity that has a misclassification for a long time in one paper that was published about the familial Mediterranean fever we were able to identify a variant that has been known as a pathogenic to reclassify it and downgrade it to VUS as per the cases that we provide. We also were able to recommend the guide development of population carrier screening programs by knowing the allele frequency of specific variants in our population in another paper that just published this year. We hope in the future to link this database to AI to automatically evaluate a variant against the database and teach the machine to predict the pathogenicity in our population based on already submitted variant. And maybe on a larger scale, we want to use machine learning and genetic risk assessment by specifically eliminating the issue of managing a huge number of variants and dealing with this various guidelines, especially for disorders with complex inheritance. From a database similar to ours, American researcher developed a machine learning algorithm to predict whether a psychiatrist should prescribe a certain drug to a depression patient based on that patient's unique medical and genetic data. The model learned from a resource of genetic data and a medical record of more than 800 patients over a period of 10 years and could predict with 85 to 90% accuracy whether the drug would ease the depressive symptoms or not. And this would help us in pharmacogenomic and genomic counseling in general. So such things will definitely impact and reshape our practice in genomic counseling, reduce wasted time for genomic counseling delivery by checking a huge number of variants, and delaying and providing testing, especially for prenatal cases. Currently, the genomic counseling is utilizing telemedicine, AI, face-to-gene, which is not for genomic counseling, but for genetic diagnosis, and some risk assessment and decision support tools like BRCA-Pro and Otis. In the future, we definitely need to focus on optimizing the genomic counseling referral and practice and set up a follow-up mechanism like the chatbots for reclassified variant just explained by the KGD database. We also have to move forward from virtual genetic education aids to interactive e-learning session. And instead from pushing awareness videos in the media, we need to be interactive and it needs to be customized for each patient to ensure genomic counseling in precision medicine era. And a lot of opportunity. Only if a series of integrated technology, our technological system connected with the genomic counselors to the clinic, to the lab, to the patient, to the insurance company, and even to the primary care physician in the primary care unit. To wrap up, approaches to genomic counseling and the role of genomic counselors will need to adapt to fit changing clinical and commercial needs in the precision medicine. This will require overcoming the challenges mentioned in this talk, including inadequate workforce, proper training to ensure competency, and integration of new technology to improve, extend, and expand the services to all population. Please allow me to acknowledge those initiatives, the KGD database, the Association of Arab Genetic Counselors, and the involvement with international genetic counselors advisory groups that aim to improve the genomic counseling profession in all aspects. I'm ending my talk here. Thank you so much. And I'm open for question or maybe when the session is ready.
Thank you very much, Ms. Lamia, for the informative presentation. If anybody has any questions to the previous speakers, please feel free to write it in the Q&A down. You find it on the end of your screen. And for our third topic in this session today, we have the topic of cancer genetic counseling. The speaker is Ms. Alia Gari. She is a senior genetic counselor at the Department of Genetics of King Faisal Specialist Hospital and Research Center in Riyadh. She is a lecturer of genetic counseling at Al Faisal University in Riyadh and a member of the Clinical Ethical Committee at King Faisal Specialist Hospital. Please go ahead with your topic, Ms. Alia. Thank you.
Assalamu alaikum. Thank you for this nice introduction, and thank you for inviting me to speak today in this workshop. I'm so happy to be a part of this team. I will share my slides, please. Lema?
Yes, just 1 minute. She's gonna put it on.
Okay, today I'm going to talk about cancer genetic counseling. Actually, this topic is very interesting to me, and I would like to share my interest with you today. I will start by talking about cancer. When we come to define cancer, it is a malignant neoplasm. When the growth is uncontrolled and capable for invading neighboring tissues or spreading to more distant sites where metastasizing. And so neoplasm is a new growth, uncontrolled cellular proliferation leading to a massive tumor. If we look at this picture here, we see that when we have a normal cell, and then this cell increase in the proliferation, then it goes into the early neoplasia. Later on, it's a progressive neoplasia. Then it turns into carcinoma and then ends up with metastasis. So these are the stages of cancer. If we look here at the normal cell division, we see that this cell is dividing, and if a mutation occurs during the division, we see that the cell damage will go into apoptosis or cell suicide, and this will help in a normal a continuation of the person in life without developing cancer. But if we see at the cancer, look at the cancer cell division, we see if a first mutation develops, no apoptosis. Then if a second mutation develops, also no apoptosis until it reaches uncontrolled growth where cancer will keep going on. So the transformation of a normal cell into cancer cell is caused by alteration in the genes which regulate the cell growth. If we look here, we see the cancer cell, and we look at the genes that are defective and in the DNA, and that is causing the cancer cell, comparing to the normal cell where the genes are functioning normally. So the cancer is a disease of the genome. If we look at the estimates of cancer in the United States in 2021, the 5 most common sites for estimated new cancer cases, and this is the most common is genitourinary system, 300,076, around 376. And if we look at the digestive system, less common, and this is the estimated new cases. We look at the new deaths, we see that the numbers also are high. When in 2010, a study was done, and the estimated for this number for males showed that 28% had prostate cancer of males, and 15% had lung cancer, 9% has colon and rectum, and so on. For females, for this number, 28 developed breast cancer, and 14 developed lung cancer and bronchus, and 10 developed colon cancer, and so on. When we come to Saudi Arabia, this statistic was done by the World Health Organization in 2020. The total population was 34 million, around 34 million, and the number of the new cases was around 27,000. So we have a high number of people with cancer in 2020, and the number of deaths was 13,000. And the number of prevalent cases during the 5 years between 2015 and 2020 was 82,000, around 82,000. So the number of new cases in 2020 showed, as the World Health Organization, that 14% in all genders had colorectal cancer, breast also 14.2, thyroid 10, and lymphoma 6.1, leukemia 6%, and other cancers. as you see. In males, colorectal was 19%, and you can look at the rest of the numbers. In females, the most common was breast, which was 29%, and the thyroid was 14%, colorectal was 9%, and you can look at the rest of the numbers. And this statistic was in 2010. Also, it showed that the number of deaths with people with colorectal cancer was 1,126, breast cancer 706, lung cancer 606. So we see that these numbers are really not easy, and we need to consider how to help these people if this cancer was inherited in the family. So all cancer is genetic, but most cancer is not inherited. Then a percentage of inherited cancer is between 5 to 10%, and the rest is sporadic. But there is the 90% is sporadic. So if we look at the somatic mutations, it's occur in non-germline tissues in the breast, colon, lung, blood cells, and it's not inherited. And as I told you, around 90%. But the germline mutations, it occurs only in the egg and the sperm, and it is inherited. And once the mutation is once inherited mutation in all cells of the body, and it accounts 5 to 10%. And also we need to differentiate between the familial and the heritable cancer. The most important part here is what is cancer genetic counseling. It is a communication process between healthcare providers and individuals concerning cancer occurrence. The elements that we discuss in cancer genetic counseling clinics, we discuss the diagnosis and taking the family history, also the inheritance pattern and risk assessment, and also we support families in decision making. When we get referrals to our clinics at King Faisal, we accept these cases if the diagnosis was of the breast cancer was at the age of less than 50 years old, and the diagnosis also of triple negative breast cancer less than 60 years, 2 primary breast or more primary breast cancers in the same person, family history of more than 3 cases of breast, ovarian, pancreatic, or aggressive prostate cancer, in close relatives include the patient. Also, we accept breast cancer and 1 additional Li-Fraumeni syndrome in the same person or 2 relatives, or 1 diagnosed at the age of less than 45. So we consider young ages. Also, breast cancer and and there is another Pitts-Jaher polyp in the same person. It could indicate Pitts-Jaher syndrome. Also, lobular breast cancer and diffuse gastric cancer in the same person. Also, lobular cancer in 1 person and diffuse gastric cancer in another person. Breast cancer and 2 additional Cowden syndrome criteria in the same person. And if there was a male with breast cancer. So what do we do in the clinics of the cancer genetic counseling? There are components of each session. When we start the session, we start by contracting. We put our agenda and we start going through the agenda with our clients. We here help them when to ask questions and when we will talk about our part of counseling, and if they have any additional concerns, then we can add it. So contracting is a term used to describe the beginning of the encounter when the counselor and the counselee share the intentions of the session. Then we move to take the family history. We start asking the right questions. How many people affected in the family, the age of onset, and the age of death, if any were died in the family, environmental exposures, if the people who had, let's say, lung cancer were smokers or not. We ask about the ethnic backgrounds. We ask about other family members, and we ask for affected individuals, cancer screening ages, overall health status. We take information in all individuals. It's important to include the presence of non-malignant findings in the proband and family members. As some cancers like Cowden syndrome, we need to include the non-malignant findings as well. Like, for example, in Cowden's syndrome, we try to ask if there are hematomas in the family, in the affected people. It is important to document general medical information, and also lifestyle factors can influence, like smoking, as I mentioned. Details about the pathology of the tumor can be very helpful. For example, if the tumor was triple negative, it could be associated with BRCA1 mutation. Then we take the informed consent, the process of obtaining patient's permission for procedure after discussing the risk, benefits, and alternatives of the procedure with the patient. These are the elements of the informed consent. We then start talking about the risk assessment, and there are three parts we need to consider. The first part is what is the chance we will find the pathogenic mutation. The client should know that are we able to find a shared mutation in the family? Are we able to do genetic testing? What is the chance that a pathogenic mutation will come out? And what is the chance that we will just have variants of unknown significance? And also, if there is a chance that we will not be able to find any mutation, what is the chance that the client will develop cancer if the mutation was pathogenic and identified? And what is the chance if family members will develop cancer? Usually they ask about their children for future genetic testing, and also they ask about the relatives. So it's important also to tell them that familial cancer is different from inherited cancer, because familial is due into environmental findings, but hereditary pattern of cancer is due to shared genetic mutation. We need to tell them that the risk is depends on the cancer history and to the degree of the relationship of an affected family member. Also, we talk about at-risk family members. We tell them that first-degree relatives of an individual with autosomal dominant hereditary cancer have a 50% of inheriting the chance of the disposition gene. And it is important to know which pattern carries the mutation, so that the relatives from the suspected lineage, for example, if it was the mother's side, then the mother's sisters should be tested for the BRCA mutation, for example. And if it was from the father's side, then it is the same. Also, it is possible that both parents are negative for their child's mutation. Then in this case, we will explain what's a de novo mutation, and the rates are high sometimes. Then we consider genetic testing. After we explain these things, we start referring them for to the lab for genetic testing. But we have a criteria also for this. If the person was affected, because I thought when I first started my clinic at King Faisal that I will only see people at risk, because my target is prevention. But most of my patients were affected with cancer. And I had less patients who are still normal and at risk of developing cancer. So if I see an affected person, then I will start by, let's say, if this person has breast cancer only, I will offer comprehensive cancer panel. And then we will, if the result came positive, then we will just go for genetic counseling and high-risk cascade testing for high-risk family members. We will ask about the relatives, and we will give them a follow-up appointment for genetic testing. If no variant was identified, then we will wait for 1 or 2 years, and we will do the analysis. But if the person have breast cancer with other cancers, let's say colon cancer, brain cancer, in the family history, here we will think of offering also comprehensive panel. But if it was no variant identified, then we will offer whole exome sequencing. So we don't offer whole exome if only the person has breast cancer, or if it was breast associated with a family history or in the same person with other types of cancer. Then, if the result was positive, then we will consider genetic counseling and testing family members. And if no variant identified, we will wait and reanalyze after 1 or 2 years. But if I see a person who is normal and with a molecular positive family member, for example, I had the family coming because their mother was positive for a BRCA mutation. So she had she was sending her daughter to the clinic for genetic testing. Here, we did targeted testing, and if positive, then we will tell her that she's positive. If negative, we will tell her this. But if it was, if she didn't have this result and she comes to the clinic with a positive family history, what we do at this stage is we offer comprehensive cancer panel testing for affected relatives. And if the panel came back positive, then we will continue with counseling, testing other family members. If it was negative and no variant was identified, we will offer whole exome sequencing. And if the result was negative, we will just stop there and reanalyze after a time. If it was positive, again, we will do genetic counseling and testing family members. So, and also from the components, we will disclose the test results. We need to discuss this ahead of time. We will tell them if they want the results by phone or in person. We need to give the patient a chance to decide. Also, sometimes they ask about their children. When should they bring their children for testing for a BRCA mutation, let's say? So we believe that whenever childhood testing is not medically indicated, it is preferable that testing decisions are postponed until the children are adults and can decide for themselves whenever to be tested. So we don't usually do anything for breast cancer before the age of 25 for females. But for other kind of cancers, it depends on the type of cancer. Then we will go to the criteria and we will decide upon that. The risk of such testing of the child and it is against the child right, and this could be an ethical issue that should be discussed among our team. So what if the testing was declined by the lab for any reason? Then it is important to refer back to the family history to make a medical management recommendation. For example, we can tell them that we will do DNA banking and you can come for screening, annual screening. We will enroll them in a prevention program if they were at risk of colon cancer or any of the syndromes that could cause breast or colon cancer or any other types of cancer. Also, we offer them surveillance, risk reduction, and tailored treatment. Because cancer genetic counseling session is a forum to provide counselors with information, support, options, and hope. Here, I always insist that they should go for surveillance, even if I could not offer it sometimes through our hospital. I ask them to go do it somewhere else or find places for them. For example, Abdulatif Jameel always have charities to help in doing surveillance for breast cancer. Also, we talk to them about the chemo prevention and prophylactic surgeries, and we have surgeons doing prophylactic surgeries at King Faisal. This is an example of a lady that I've seen, a 51-year-old lady that I've seen at the Cancer Genetic Counseling Clinic, and she was diagnosed at the age of 44 with breast cancer. Later on, she developed thyroid carcinoma, and then she did nephrectomy because she had renal cell carcinoma. This lady came to the clinic, and neither of her children were tested at that time. And she has 4 boys and 2 daughters. She also had a family history. Her father was diagnosed with colorectal cancer at the age of 50. The paternal aunt diagnosed with breast cancer at the age of 66. The other paternal aunt had colorectal cancer, but she couldn't recognize the time of the diagnosis. This lady was diagnosed with Lynch syndrome. She brought her genetic test results with her. She was positive for a pathogenic mutation in MSH6 gene. So I asked her to bring her two sons later on, where they were tested, and the eldest was negative for this mutation, but the second one was positive for the same mutation that she had. And he was offered genetic counseling, and he was enrolled because he was 24. He was already enrolled in one of the prevention programs that we had by Dr. Asani at that time. And they told him, they booked him for screening. So if we look at the function of this MSH6 gene, this is an important gene. It's a part of the MMR genes, and these are a set of genes that mismatch repair genes. They provide instruction for making protein that plays an essential role in repairing the DNA. This protein helps fix the errors that are made when the DNA is copied, and it works with another protein that comes from the MSH2 gene and makes this protein complex. The complex identifies the location on the DNA where the errors have been made during the DNA replication. And the MMR genes are responsible for identifying repairing single nucleotide mismatch repair genes. I will not go into the function of these genes to save time, but if any of these genes get impaired, they are responsible for Lynch syndrome. And this is an autosomal dominant condition caused by germline pathogenic mutation in a mismatch repair gene. We see that 50% is caused by the MSH2, so it is the most famous, and then we have the rest of the other genes. This is an example that when we have a case like this in the clinic, we explain to the patient that she is at 52 to 82 risk of colorectal cancer, and also 25 to 60% of endometrial uterine cancer. Gastric cancer is 6 to 13%, ovarian cancer 4 to 12%, and the risk of other Lynch syndrome related cancers is lower. We inform her that it could include the small bowel and hepatobiliary and urinary tract cancer. And then we should tell her that who should be tested for Lynch syndrome. We usually go by these criteria, either the Amsterdam based on the family history or the revised BICIS guidelines. And I will, just to save time, not to go through them. But for the medical management, which is I'm interested to share with you today, is if, for example, this lady, I told her that she has to go for colonoscopy every 1 to 2 years, starting at the age of 20 to 25, as her son, who's normal, completely normal, with positive test results, and also upper GI endoscopy every 1 to 3 years, and it starts from the age 30 to 35. And also complete or partial colectomy are options following the CRC diagnosis. Annual physical exam is important, including neurological and skin exam, well as annual urinalysis screening for urological cancer starting between 20 to 30. Medical management, many of the females can be educated and the signs and the symptoms, and they can refer females to gynecologic oncologists to be screened also. And because of screening can be ineffective, female patients can consider undergoing prophylactic total abdominal hysterectomy with bilateral oophorectomy by start of menopause or after completing their childbearing. So for this lady, the age was perfect for going for these prophylactic surgeries. And we talked to them that at least 2 first-degree relatives with any Lynch syndrome relative cancer, regardless of the age of the cancer, a family member with colorectal or endometrial cancer who meets one of the above criteria, should come for this testing. And also we tell them that family member with confirmed diagnosis with Lynch syndrome also should go with this screening. And this is just the papers that was really interesting. that gave information, and it was published in 2017 about the nutrition and food, do alcoholic beverages, obesity, and other nutritional factors modify the risk of familial colorectal cancer. And the aim of the study was to see if individuals with family history of colorectal cancer are at higher risk of colorectal cancer than the general population, if lowering the exposure to modifiable risk factors and notably nutrition factors has an influence. So the results here showed that the combination of family history and also higher consumption of alcoholic beverages, red processed meat, which is we see a lot in our society, people eating red meat, and overweight also, which is common in our society, increased risk of colorectal cancer. Strong increases observed with combination of a family history of colorectal cancer and unhealthy dietary pattern lifestyles. Also, statistically significant interaction between these nutritional factors, family history, and colorectal cancer, colorectal risk are reported. And other data were inconclusive in the rest of the study. So the finding highlights that alcoholic beverages, red or processed meat, overweight, obesity, and exposure to multiple unhealthy dietary nutritional behavior could increase the risk of colorectal cancer. And the better information of these patients and of health professionals on these nutritional modifiable risk factors is recommended. Also, there were recommendations. This paper was published in 2006, a systematic review for recommendations for the care of individuals with inherited predisposition to Lynch syndrome. The objective was to review the cancer risk and data on screening efficacy in the context of Lynch syndrome and to provide recommendation for clinical management. So the management is not really different from what I just mentioned, but it's insisted on frequent colonoscopy, endometrial surveillance, screening for other cancer, prophylactic surgery, for example, ciliectomy, and chemo prevention and lifestyle modification, like example for exercising. So today I have explained briefly about cancer and the components of the cancer genetic counseling session as we go through King Faisal. And case, also I explained the case scenario of a patient who came to the clinic with Lynch syndrome. She was already developing the symptoms, and her son was positive, but he was asymptomatic. Thank you. Any question?
Thank you very much, Ms. Alia, for the very interesting topic, really, and very informative. There are some questions. There are some questions. Someone is asking, what is the difference between familial and hereditary cancer? For example, if my grandpa has lymphoma, may the chance to be affected is more than the general population, right? In this case, is it familial or hereditary?
Okay, let's start with the first part. The difference between familial and hereditary is that hereditary, that there is a known targeted mutation, and this affected person has this mutation, and this is 5 to 10%. If we go to familial, where people in the family, let's say siblings, develop cancer, for example, breast cancer. Four sisters. I had a family like this who had 4 sisters who developed breast cancer, but by testing them all, they were all negative for any mutation. And that was due to environmental factors. The environmental factors that cause cancer are plenty. It could be hormonal therapy, it could be obesity, it could be smoking, it could be the nutrition, as we saw here. There are plenty of factors. But if it was in one family, then we call it familial. But still, it's not considered inherited. It's considered due to environmental factors, sporadic. It's a part of sporadic cancer, but it is familial because it is in one family. Can you go back to the second part of the question, please?
Yes, sure. So she says, if my grandpa has lymphoma, what's the chance to be affected? Is it more than the general population? And is this case familial or hereditary?
Well, if he was tested and he was negative and he had cancer, then the chance, if she was sharing the same environmental factors with her grandfather, then her chance is higher than the general population. But because she is being exposed to the same environmental factors as her grandfather. But if she was not because sporadic cancer usually is higher when the people gets older. Above 62, 1 in every 8 women in the US develop cancer. So it is higher because of age related. So then we can say that if she was sharing the same environmental factors, then she will be at risk when she is at the age of her grandfather, but not before that.
Thank you very much, Ms. Alia. Ms. Lamia, there's 2 questions for you. The first question is, how can we reach the variant database of Saudi population?
There is, I don't know if it's in general Saudi population because there is many database. I'm not sure if the Saudi Genome Project database is available, but our database called the KGD, and our database is reachable through an email request that can request an activation. And once you send us through the email, I think did you put it on the slide? Yes, it's here. So you just email the bmg@ngha.md.sa. Asking for activation with your credential and the institution you're coming from, and we will provide you access with the password and username.
Okay, thank you very much. And Ms. Lamia, the other question is, a person is suggesting, why don't you ask the parent to sign a consent form for pregnancy termination for affected baby? I think this will help them understand that they are representing each other and this is our nature.
I think Reem Dghayman, she was referring to the slide that I was talking about, the one question that mostly answered wrongly. So that question was not about, I didn't mention a parent. I was specifically saying a legal guardian. Not all scenarios we have a legal guardian as a parent. One scenario is a minor pregnant woman whose legal guardian is her father, which is the grandfather of the pregnancy. In all setting, not only in pregnancy and termination, we involve both parents. But some of the time, one of the parents is not in the picture, and the other companion to the clinic or to the session is a legal guardian for one parent, but not necessarily for the affected baby or the pregnancy itself. So these issues that contain ethical dilemmas, and in where scenarios, for example, specifically Reem, my question was a pregnant woman who's 17 years old, and she is coming in 15 weeks. She referred by her physician. She never heard about genetics, and she wants to get information. Her father, the grandfather of the pregnancy, is refusing any information, denying any genetic condition in the family. And I always ask my genetic counselor student, how you will deal with such a situation. And the aim of the question is to understand how far they understand our culture, how far they are aware of the local law, Sharia. Thirdly, how far they are aware of the institution policy. So that was, I hope that this explain for you, Reem. Definitely for parent who both of them attending the session, they will be assigned the consent for the affected baby.
Thank you very much, Ms. Lamia. So we are done with the second session for today. The third session, Ms. Mira will be starting it soon. Thank you, everybody.
Hello, everyone. Hello? Hello? Hello, everyone.
Yes, Munira, we hear you.
Hello everyone, welcome to the third session of our webinar, Genetic Counseling, the Practice and Challenges. My name is Munira Sherry and I'm a recent graduate of Masters in Genetic Counseling from Faisal University. I earned my bachelor degree in biomedical sciences from the University of Southampton.
Munira, your voice is a little bit muffled. Can you raise your voice, please?
Okay. Is it clear now?
Yes, now it's better.
My name is Munira Sherry and I am a recent graduate of Masters in Genetic Counseling from Faisal University. I earned my bachelor degree in biomedical sciences from the University of Southampton, UK, specializing in neurogenetics, and I'm also a member of the Awareness and Genetic Counseling Committee at SSMG. I'm very excited and proud to moderate the final session. We are going to have 4 speakers in the session. Khawla Al-Faiz from Prince Sultan Military Hospital, Sarah Luwaisi from iGenomics, and Fawzul Harthi from King Abdulaziz City for Science and Technology, and last but not least, Dr. Nikki Tavener from Cardiff University at UK. This will last for 1 hour and a half, and I want to remind each speaker that each talk is to be 20 minutes long. At the end, we'll have 10 minutes for questions and 5 minutes from the sponsor, Centogene. Questions to the speakers can be posted by using the Q&A function on Zoom. And to kick off the meeting, first speaker is Ms. Khawla Al-Faiz. She's a licensed genetic counselor under the pediatric division at Prince Sultan Military Medical City, Riyadh, and she was the chief of the cytogenetic and molecular genetics lab from 2002 until 2018. Ms. Khawla, you can start.
Good evening, everybody, and thank you, Ms. Munira, for the introduction. I need to share. Would you stop other screen sharing? Yes. Okay, I'm Khawla Khair Al-Faiz. My talk today will be about laboratory genetic counseling. What is the practice? Munira insists that we have to stick to the 20 minutes, so I'm going to start the marathon. So give me an excuse if I'm fast. These are my objectives. Genetic counselor is a healthcare professional with specialized training both in genetics and psychosocial counseling. Their skills is to explain complex genetic concepts in understandable terms, provide psychosocial support related to genetic diagnosis, assessing genetic risk based on family history or test results or both together. Genetic counselors are available to consult with clients and clinicians regarding optimum testing strategy and test result interpretation for genetic tests in general or at a patient-specific level. Everything is moving toward genetics nowadays, so we can find them in cancer clinics, prenatal practices, pediatric genetic clinics, neurogenetics, cardiology, and laboratory settings. Laboratory genetic counselors who are working in the lab do not interact with patients directly. They help optimize patient care by ensuring that the right test is ordered at the right time on the right patient. Genetic counseling to avoid duplication or misuse of the reagent, they may canceling a large gene panel and running targeted testing for a known familial mutation instead, or canceling a genetic test that had already been run on the patients in the past. They answer questions from genetic providers as well as other clinicians who don't have access to genetic service at their own institutions by pre-test consultation with the clinician to ensure that the most appropriate test is ordered, or post-test consultation to discuss the complex results. They can help providers understand complex genetic test reports and the implication for the patient and their relatives, plus guide clinician in ordering necessary follow-up testing for patients or their families. There is a paper published in 2013 stating that genetic counselors saved $194,000 in 3 months period at the Mayo Clinic Hospital through cancellation of duplicate orders and revision of misordered tests. I'm not talking about saving money, but also about saving staff timing and the misuse of the reagents. Laboratory genetic counseling, I'm talking now about the genetic counselor who's working in the cytogenetic lab. Cytogenetics is the study of chromosomes and genomic structure, function, and variation, and their role in human disease and hereditary. We have 3 methodologies in the cytogenetic lab. The first one, karyotyping or chromosomal analysis, where we obtain the chromosomes, analyze them to detect if there is structural or numerical abnormality. The resolution for the karyotyping is 3 to 5 megabase in 550 bands level. We have fluorescent in situ hybridization or FISH, where we can analyze only the region of the genome that is complementary to the FISH probe. The resolution for FISH is 100 kb, and we have the genomic microarray analysis, where whole genomic DNA from a control and a genomic DNA from a patient are differentially labeled with 2 different fluorophores and used as a probe that are co-hybridized competitively onto nucleic acid targets. The resolution is 10 to 100 kb. It has the highest level for detection of copy number variation, but it has the disadvantage that it's not able to detect the balanced structural abnormalities. So keep this in mind. What is the indication for cytogenetic analysis? Postnatally, we might have referral for newborn with burn defect, malformation, dysmorphism, ambiguous genitalia, growth like failure to thrive, growth delay, short stature, cognitive, intellectual disability, learning disability, developmental delay, neurological like hypotonia, seizure, ataxia, behavior like autism, obsessive compulsive disorder, and psychiatric illness. We may also have a referral for adolescent, like a history of infertility or spontaneous abortion, birth of a child with a chromosomal abnormality, female infertility like amenorrhea, primary or secondary ovarian failure, premature menopause, and male infertility like azoospermia, oligospermia, or hypogonadism. For prenatally also, we might have a referral for abnormal ultrasound finding like cystic hygroma, hydrops, cardiac defect, other malformation like intrauterine growth retardation, or we might have an abnormal non-invasive prenatal testing result, like if they detect any aneuploidy, they need to confirm it by another technique like FISH to exclude placental mosaicism. Also, we might have amniotic fluid for a pregnant lady whose age is 35 or above to exclude aneuploidy as well, and parental or familial chromosomal genomic abnormality. I want here to talk about the heteropolymorphism or polymorphism, which is found in the, which might found in the cytogenetic lab. Some labs, or in general, the labs do not include this in their reports, but just in case, if you see it for any reason, if any lab put this in the report, please be familiar of it. I'll talk about the heterochromatin region in chromosome 9 and the heterochromatin region in the long arm of chromosome 6 and chromosome 1 and the distal part of the chromosome Y. So increasing or decreasing in the heterochromatin region, it has no impact in the individual condition. Also, the acrocentric, there is a stock and satellite. Sometimes there is a variation in the length, or maybe it's absent in some chromosomes. Also, it has no impact. There is inversion 9, and sometimes there is a common finding in the cytogenetic lab that you might find a satellite in the distal part of chromosome Y. Please remember that this is a benign variation among normal population, and as a genetic counselor, no need to do further investigation. I'll go now through a case discussion of 3 cases because I do believe that this discussion will, it's a good source of knowledge. So my first case is a 28-year-old male with severe oligospermia. The request form received with the karyotype and SRY gene deletion. The cause for male infertility is chromosomal abnormality. The individual might have chromosomal abnormality, like let us say Klinefelter 47XXY, which cause infertility, or he might have balance structural rearrangements. Y chromosome microdeletion, the azoospermia factor, also single gene anomaly, and cystic fibrosis, which cause congenital bilateral absence of the vas difference. All these cause male infertility. Now, as a genetic counselor, we'll approve the karyotyping as a first-tier investigation. When we did the karyotype, we found that he has 46XY, apparently normal male karyotype. Now, are we going to proceed for SRY gene deletion by FISH? No. We're going to discuss it with the clinician and tell him that he's a male with male characteristic, but his wife is not conceiving. So we could suggest that you may replace this test by Y chromosome microdeletion, because male with infertility, usually 15% of them have a deletion in the azoospermia factor region. Azoospermia factor region divided into A, B, and C. They are present on the Y chromosome and on the long arm and are most important for spermatogenesis. Deletion of azoospermia A and B, usually there is no intervention, which means retrieved sperm is almost zero in their case due to the maturation arrest. Patients with deletion azoospermia C usually have severe oligospermia, and this patient is candidate for testicular biopsy, where an island of spermatogenesis can be found and sperm can be retrieved, and this patient can proceed for ICSI. For counseling, we need to counsel the patient that this is a Y-to-Y transmission, and if the fetus is boy, he will have the same complication like a father. Another case, the clinical details with a period of infertility and recurrent abortion. So the test requested was karyotyping for both parents. When an order for genetic testing is received, a genetic counselor needs to review the reason for the testing to confirm that it matches the order test. After testing is complete, the counselor is involved in reviewing the result and assessing in the preparation of easy to understand final reports for healthcare providers and the patients. So for karyotyping, we did karyotyping for this couple. The father has a 46XY, apparently normal male karyotype. When we did karyotype for the mother, she has a 45XX Robertsonian translocation 1421 Q10 Q10. As you can see, she has 45 chromosomes, but she's a balanced carrier because there's no loss or gain in the genetic material. And this is a common Robertsonian translocation due to the homology in the P-arm stock in the chromosome 14 and 21. Now, to counsel this patient, to know what further investigation we need to know, what further tests we need to help them, we have to predict the outcome. To predict the outcome, we're gonna do the meiotic segregation. Because it's acrocentric, we will draw the trivalence events where the translocated 1421 will align together with the normal chromosomes. So we have alternate where the translocated chromosome 1421 will go to one gamete and the normal 1421 will go to other gametes. These two gametes, if fertilized with normal sperm, the result will be normal phenotype. But in this case, remember that he will have a balanced translocation like the mother. In adjacent one, these chromosomes, chromosome 14, the translocated 1421 with the normal 21 will travel to one gamete, and the monosomy 14 will travel to another gamete. Or the adjacent two, where the 1421 with the normal 14 will go to one gamete and the monosomy 21 will go to another gamete. So if these fertilize with normal sperm, This is unbalanced gamete. Usually the last 3 is unviable and will result in very early fetal loss. That's why in the clinical details, they said a period of infertility. Maybe the mother was pregnant and after 3-4 weeks, she get an abortion without even recognize that she was pregnant. This is the only unbalanced gamete, viable gametes with trisomy 21. So we'll get a baby with Down syndrome, dysfunctional type. Okay, and this is if we have a child for this couple. This is the karyotyping 47XY Robertsonian translocation 1421 Q10 Q10 plus 21. Okay, evidence-based counseling, the theoretical recurrence risk for a Robertsonian carrier parents to have a live-born offspring with Down syndrome is 1 in 3. This is the theoretical. Okay, but however, only 10 to 15% of the progeny of carrier mothers and only 2 to 3% of the progeny fathers have Down syndrome. In a carrier parents with translocation 2121 or isochromosome 21q, the recurrence risk is almost 100%. We can offer them non-invasive prenatal testing at 10 weeks gestation, and we could do a FISH if the result obtained abnormal, just to confirm this finding. We offer a karyotype for the carrier's parent sibling to detect any potential carrier, and PGT or PGD is an option, despite the fact that chromosomal rearrangement is really challenging for the PGD center. Maybe we can talk later if we have time at the end. Case number 3, the last one. We receive amniotic fluid with abnormal ultrasound findings, microcephaly, renal anomalies, congenital cardiac defect, abdominal enlargement, and less perceptive for fetal movement. Usually, when we have any unexplained developmental delay, intellectual disability, autism disorder, or multiple congenital anomaly, we proceed for chromosomal microarray. And that's what we did in cytogenetic lab. When we did chromosomal microarray, we detect duplication of 20 megabase on chromosome 11 and around 1.7 megabase duplication on chromosome 22. So the cytogenetic lab give recommendation that testing the parents are highly recommended. This result is a bit confusing for us because when we have a deletion on one chromosome and duplication on other chromosome, I would think that one of the parents might have a balanced translocation. If we have a duplication and deletion on the same chromosome, I would think that this is a recombination of one of the parents have inverted chromosome. If we have a duplication in one chromosome only, so I would think that one of the parents have balanced insertional structural rearrangement, but duplication on chromosome 11 and duplication on chromosome 22, it was a little bit confusing. So the clinician sent the blood for the parents and write chromosomal microarray. Usually chromosomal microarray, we can't perform it for the normal individual with normal phenotype or balanced translocation. So we replace it by karyotyping. The father, when we did the karyotype, he has 46XY, apparently normal male karyotype, and we did karyotype for the mother. The result revealed that she has a reciprocal translocation between the long arm of chromosome 11 here and the long arm of chromosome 22 at Q11.1. So, as I said, to predict the outcome, we need to draw the pactine phase in prophase 1, but this time we'll not draw the trivalent, we'll draw the quadrivalent recombination because we have these two derivative chromosomes. So in alternate segregation, the two derivative chromosome will travel to one gamete, or the two normal chromosome 1122 will go to another gamete. If these fertilized, the result will have a normal phenotype, but one of them, this gamete, will have the same translocation like the mother. In adjacent one, The normal chromosome 11 with the derivative 22 will go to one gamete, or the derivative 11 and normal at 22 will go to another gamete. In adjacent 2, the chromosome 11 and the derivative 11 will go to one gamete, and chromosome 22 and the derivative 22 will go to another gamete. These, when fertilized with normal sperm, the result will be a partial deletion or duplication, either for chromosome 11 or chromosome 22. These gametes are unviable and will result in a very early fetal loss. We have a 3-to-1 mode of segregation where the derivative chromosome will go with the normal chromosome 11 and chromosome 22 here. This derivative chromosome will go along with normal chromosome 11 and 22, as I said, into daughter cells. The additional derivative chromosome here, we call it, after fertilization, Emanuel syndrome. This is the most abnormal viable outcome because there is no material is lost in this segregation. However, there will be a partial trisomy. So this is the viable gametes. When this fetus born, they send his blood for karyotyping, and that's what we found. The karyotype revealed 47XY plus supernumerary chromosome derivative 22, which is the result of translocation 1122 from maternal sides. So as counseling, we explain the result and the risk. We take pedigree, detailed pedigree to decide who's in risk from relatives to be tested. Apparently balanced chromosomal rearrangement usually will produce no phenotypic effect in the carrier. However, during gametogenesis may lead to malsegregation of the carrier's chromosome, which in turn may lead to recurrent pregnancy loss, as we see, or abnormal live birth. Pre-implantation genetic diagnosis may be an option in future pregnancy for this couple. The possible outcome always should be discussed with the genetic team for approval of termination. If we get the approval of termination, we can proceed for another step. But sometimes the genetic team is a little bit hesitant, so they may refer this to the another clinician like nephrologist, cardiologist, or neurologist. And I do believe when we reach this point, at the end, we'll ask the patient to get fatwa. If the termination of pregnancy approved, antenatal testing performing chromosomal microarray may be an option, knowing that normal results couldn't tell if the fetus is carrier for the balanced translocation like the mother. I think I reached 20 minutes, so I will not go through this. Thank you.
Thank you very much, Ms. Khawla, for this great talk. We can move now for second speaker. Our second speaker is Sarah Al-Owaisi, is currently working as a senior genetic counselor in iGenomics, Middle East. Previously, she worked as a genetic counselor in King Khalid University Hospital for 4 years. Also, from 2010 till 2017, she worked as a research associate in genetic department at King Faisal Specialist Hospital and Research Center. She has a bachelor degree in biotechnology from Egypt with honor degree, in addition to postgraduate master in genetic counseling from Al Faisal University. Excellence with a first-class honor. She is volunteering weekly time to counsel families in different support group through WhatsApp. Sarah, you can start.
Thank you so much, Munir, for this introduction. And first, I'd like to thank the committee for inviting me to give the lecture for this webinar today. As I can see that we have a good number of knowledgeable and experienced genetic counselor in Saudi Arabia It was a dream that come true. I'm happy really to see this number of genetic counselors who are sharing their experience and knowledge today. Today I'm going to talk about the molecular laboratory and adult genetic counseling. We'll try to cover the outline of my topic within the frame time. As we know that genetic counseling is an expanding field, we have different genetic counselors who are working in different settings, starting from pediatric, prenatal, adult counseling, reproductive, and cancer setting. This counseling has these unique specialties, like provide the clinical health care with the educations, and the genetic counselor provide the support for the individual and families with inherited genetic disease. For the genetic counselor, we know that they provide the services to patients across the lifespan by assessing the family history to determine the disease risk. They are assisting in the genetic testing, and they provide guidance to help the patients in order to make informed, autonomous decision regarding their health and their reproductive decision. Here I add some articles that address the role of genetic counselor in laboratory setting. As a lab genetic counselor, I provide different ways for counseling my patients, including in-person or phone or video conference. I work as a healthcare educator for business development who are working in the market field. Usually support the doctor to choose the right test for their patients, as well as helping them to understand the genetic report. We offer the free test, pre and post-test counseling for all the patients who are pursue testing in our company. Today I'm going to talk about adult genetic counseling, and as we know that the genetic counseling for adults include different areas like cardiovascular, psychiatric, neurology, and fertility or cancer. The adult patients who diagnosed with or at high risk for adult onset disease, they might have different questions and concerns to raise it during the genetic counseling. And I'm sure that the genetic counselor need to have more time for those patients during counseling. The first case I would like to address in Fragile X syndrome. I think Dr. Ahmed give a highlight about this syndrome, but I will not talk too much about this syndrome. But I need to address that this syndrome is caused by a change in the gene on the X chromosomes, which is called the FMR1 gene. This protein is, this gene produces a protein that helps the brain to function normally. And this gene is really very important in the development of the brain and other
Miss Sarah, we can't hear you.
Sorry, Munira, can you hear me?
Yes,
no?
Yes.
Oh, okay, so this gene produces a protein that helps the brain to function normally. And all the cases of Fragile X syndrome are caused by expansion of the CGG triplet repeat that found in the FMR1 gene. Normally, this DNA segment is repeated from 5 to 40 times. But in people with Fragile X, this CGG repeated like more than 200 times. For Fragile X, the pre-mutation trinucleotide repeated in the FMR1 gene may expand over generation to be a full mutation with more than 200 repeats. And this expansion is associated with silencing of the FMR1 promoter through the epigenetic mechanism that involve the DNA methylation of the CGG repeat and the other surrounding regulatory region. This condition is inherited as X-linked dominant disease pattern, with very rare exceptions where the FMR gene is deleted or if the gene mutation came from either the individual's father or mother. Here we have two scenarios where the father is the pre-mutation carrier, so he will pass the Y chromosome for his son, so none of them will be affected. And he will pass the gene mutation to his daughter, and therefore they will be a pre-mutation carrier. On the other side, if the mother is a pre-mutation carrier, so it means that she has a 50% chance for passing this mutated gene to her future pregnancy. And the chance for their child to be affected, it depends on the CGG repeats. Usually, I use this table when I counsel my patient. As Dr. Ahmed explained, that the number of the CGG repeat is divided in 4 groups. But if the individual have like more than 2 repeats in the FMR1 gene, so it means that the individual is considered to have a full mutation. And this mutation will result in full expression of Fragile X in male and variable expression in female. Usually the pre-mutation carrier do not have manifestation for Fragile X in cognitive deficit or behavioral abnormalities, but they are at increased risk for development of a Fragile X associated disorder, which is the premature ovarian failure and the Fragile X tremor and ataxia syndrome. The smallest repeat size that was previously reported to expand to a full mutation in 1 generation is 59 repeats. I will address this, come to this point at the end of my presentation, but usually I use this table while counseling my patient, where I mentioned this, the number of the CGG repeat and the percentage of expansion to a full mutation in her future pregnancy. Coming to know what's the role of the RNA in the pathogenicity mechanism of Fragile X syndrome, there was an evidence that the carriers of the pre-mutation allele of the FMR1 gene, that they have an elevated level of the FMR1 mRNA compared with the individual with the normal repeats. And the pre-mutation carriers have the increased level. This level has high toxicity to the neurons and associated with the neurodegeneration. This hypothesis and this model was studied before in many articles, and they called it the RNA toxic gain of function. Other factors also were discussed that playing the role in the pathogenicity of this disorder. But whether or not the case of a Fragile X premature ovarian failure or the mRNA level, if the mRNA level has a direct role in the pathogenesis of the ovarian dysfunctions, this issue was discussed in the previous articles, and it seems clear that the penetrance and the age of onset of Fragile X premature ovarian failure and the elevated level of FSH hormone level is associated and correlated with the expansion of this repeat loop. If you can see from this table that approximately 80 to 90 repeats, if like the middle range, if the pre-mutation this if the mother is a carrier of the pre-mutation in this strain. So it means that she confirmed that she has a greater risk for premature ovarian failure. On the other side, for the male to have the Friedreich Fragile X with tremor and ataxia syndrome, it was noticed that the penetrance increased with both age and CGG repeat length, and the incidence of this disease is at least almost like 50% in men by the age of 70 or 79. So for me, Fragile X has like a potential life impact on the patient and his family. So this is why I do believe that counseling these cases are especially challenging for so many different reasons. I can see that the patient, they need more time. Explaining the complex inheritance is not easy. And the genetic counselor need to address the emotional address the emotional side that may have in the future for this patient, or if she identified to be a carrier of the CGG repeats. Usually I counsel my patients if they are found to be a pre-mutation carrier, that they have a risk to have an offspring with a Fragile X syndrome, but they have an also risk for Fragile X premature ovarian failure and Fragile X tremor and ataxia syndrome. So I usually recommend that the genetic counselor need to take a full family pedigree with at least 3 generations. She can address some questions regarding the family history of the family members. If one of them found to be have like premature ovarian failure or early menopause, any kind of a tremor or ataxia, all this information can help the genetic counselor to have a hint that this is the case of maybe Fragile X syndrome. So the pre and post test counseling is highly recommended for those cases. The first case that I would like to address, if a woman is identified as a pre-mutation carrier and she agrees to do like a prenatal diagnostic test for Fragile X. What's the scenario if the fetus does not carry the full mutation, but the result came back positive, that the fetus has inherited an allele in the pre-mutation range, and the fetus gender is a female in this situation? How we can counsel these cases? Usually, I start explaining to my patient that in this scenario that the pre-mutation carriers usually they do not show signs and symptoms of the disease, but we need to disclose the information pertaining the risk that their fetus may have to develop like 2 adult onset condition. And also we need to address the potential benefit and the risk of doing the prenatal. Sometimes also discussing the carrier status of the other family members is deserved to have an attention. Finally, it remains unclear whether any direct treatment or preventive option will be available for these 2 conditions. So this is the important points that I'd like to highlight for this case. The other case, the same, if the mother found to be a pre-mutation carrier, and we identify that the female fetus has a full mutation over 200 repeats in a prenatal setting. This significant, this case has a significant counseling challenge, because the counseling, it will not be easy for this. We need to talk more to explain to our patient in a very simple way the process of X inactivation We need to address that the X inactivation may modify the clinical phenotype of Fragile X in female carriers. And also, if the percentage of the active chromosomes with normal mutation allele is higher than the active chromosomes with a full mutation allele, maybe the symptoms is less severe in this situation. But unfortunately, the ratio of these active chromosomes cannot be predicted prenatally. And in general, like 50% of female with a full mutation will have a cognitive and behavioral features of Fragile X. So this uncertainty about the resulting phenotype also raise the anxiety of the couple. And this potential dilemma in counseling lead some of the authors in the previous articles to suggest that fetal diagnosis of Fragile X should be reserved for a male fetus only. The other case, if in the genetic counseling, if we identify an individual with intermediate Fragile X allele carriers, so if the repeats in the intermediate range, so it means that we are in the gray zone. This result also cause moderate anxiety in patients because this result is not called normal, because these intermediate repeat can expand. Is not the repeats are not unstable and can expand in the future generation. Up to date, there have been no report of CGG repeat of less than 56 expanding to a full mutation in a single generation. However, they mentioned that this intermediate allele can expand into a full mutation within 2 generations, not 1 generation. And usually I highlight this point to my patients. The other points, like offering the invasive prenatal diagnostic test for patients with intermediate range repeat is not generally recommended. And the genetic counselor need to address the importance of testing the other family members who are in the same generation or the other future generation in order to determine the allele stability and to identify the individual who are at risk of having an offspring with the full mutation. The other issues to consider for Fragile X syndrome, that mosaicism was also reported in Fragile X, and mosaicism, as we know, that happens after fertilization. Mosaicism probably occur because the CGG repeats expand to a full mutation in some cells, where in other cells the repeat number fails to increase in size, and the repeats remain in the pre-mutation level. Based on different observation, the CBS material that taken from the placenta at 10 weeks is frequently unmethylated, and the methylation of these CGG repeats appear to occur on this stage. So the other point that the genetic counselor need to address, that the fully expanded repeats sometimes fail to undergo methylation, or sometimes the methylation is not happen, or is incomplete, and the mosaicism affected males appear to be associated with maybe a better diagnosis than the Fragile X cases. The other interesting part, that Prader-Willi syndrome phenotype was also seen in patients with the Fragile X, but without the cytogenetic or the methylation abnormalities in chromosomes 15. And both Fragile X and Prader-Willi patients were reported to have obesity and hyperphagia. Delayed puberty was seen in patients who had entered the puberty. Also in infancy period, the infant hypotonia and poor sucking was also seen. The autism spectrum is very associated with the Fragile X syndrome and need to be addressed also. The other case that I have were 9-year-old girl who was referred for investigation for her gross obesity, hyperphagia, learning difficulties. Her IQ is 65 with particular deficit in verbal reasoning. Our patient was the third child for unrelated parents. The mother reported no history of neonatal hypotonia or feeding difficulties. She achieved her motor milestone within the expected time, but presented with a speech delay, communication, learning difficulties, and behavioral problem. The older brothers were also known to have intellectual disabilities, but unfortunately, they were not available for assessment. The mother is divorced, so and the two affected brother living with the father, but both brothers were reported to have the similar stature and build. The mother is well and healthy. She has a normal cognitive ability, no history of a premature menopause in the family. Open the physical examination. The patient was tall, obese. She had small hands and feet with normal skull shape, normal ear morphology, and no specific dysmorphic features. We performed first karyotype for this patient, and after that, the cytogenetic analysis revealed a 47XX karyotype, which is consistent with the XXX syndrome. The mother was counseled about this condition accordingly. But like after 6 months, the mother came to a genetic counseling session requesting the genetic testing for Fragile X syndrome. She brought a medical report from one of the government hospitals where they diagnosed one of the affected boys as having Fragile X syndrome. So we perform at that time genetic testing for the mother and for the affected girl. The mother, the DNA was isolated for the mother and the affected girl. We used the PCR to amplify the FRAX-A locus. For both the mother and the girl. We noticed that the FRAX-A allele is corresponding to 38 CGG repeats, and the southern blot analysis showed like discrete bands that presented with a fully methylated expanded allele of approximately 550 repeats. This was darker than the normal size band. Also, the laboratory testing for the mother also revealed that she is having a pre-mutation in the range of 84 to 92 repeats. So at that time, we conclude that our patient having a XXX syndrome. She diagnosed with Fragile X according to the CGG repeats. She diagnosed clinically as having a Prader-Willi phenotype. We counseled this patient that the Prader-Willi-like phenotype of Fragile X, including the severe cognitive difficulties and behavioral problem. Mainly the obesity for this patient maybe was secondary to extreme food consumption, but the patient tall stature may be features of both Fragile X and the XXX syndrome.
Thank
The
you very
other
much, Sarah. I'm sorry I have to interrupt. Thank you very much for your presentation. That was so great. We need to move on to our third speaker. It's Ms. Fawz Al-Harthi. Fawz is a licensed genetic counselor. She is the co-founder of Your Genetic Counsel platform. Also, she is the Deputy Director for the National Research and Development and Innovation Coordination. In addition, Fawz is the project manager of Saudi Genome Project 2 at King Abdulaziz City for the Science and Technology, CACS. Fawz, sorry for the delay, and you may start your talk.
Hello everyone, Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for having me. It's such an honor to be part of this webinar. I have 20 minutes, but I'm gonna finish it in 10 minutes because I know it's too late now. So basically today I'm going to talk about the impact of the online platform on the genetic counseling services during the COVID-19 pandemic. I know that everyone is aware that the COVID-19 pandemic has significantly impacted the healthcare industry worldwide. And Saudi Arabia is one of the many countries that were significantly impacted by this deadly viral disease. During the pandemic, there's a lot of clinics that have been shut down. And one of the clinics that have been working at King Fahd Medical City, they were shut down. The patient, they were struggling. And clinical geneticists and genetic counselors worldwide, they were compelled to implement drastic changes in their service delivery models so they can continue providing the genetic counseling. Therefore, I would like to really highlight that digital communication and future technologies are playing an important role in our daily lives. It's no surprise that technologies nowadays have been shaping our practice in healthcare, specifically in the practice of genetic counseling. So what is online genetic counseling? Online genetic counseling is defined as the use of patient portal to provide information to the patients and their families. So with the portal, you will be able to communicate with your counselor, requesting appointments, medical tests, going through your genetic testing, and also your medical reports. Like other medical fields, genetic counseling has made a swift transition from the traditional usual care or the in-person mode of genetic counseling to the online genetic counseling. So I would like to go through briefly about my platform, which is Your Genetic Counsel. So Your Genetic Counsel, it's an online clinic that's based in Saudi Arabia. It's a secure web-based portal where we have 9 genetic counselors. They are certified. We all volunteer in this portal. We have received more than 600 requests worldwide. We were aiming that we want to just focus in Saudi Arabia, but alhamdulillah that we have reached even outside Saudi Arabia. We have had consultation from Egypt, from Yemen, from Iraq, from different countries. A patient, they have full control on their file. They can recap the information whenever they want. The genetic counselors will be able to reply for them within 24 hours. We also provide support counseling, post and pre-genetic counseling. So basically, I just want to highlight this presentation is part of a study that we conducted. So we started by having a literature review. We went through some literature review. The idea was, first, we were highlighting that the genetic counselors, mainly they were mostly in the urban areas. This is one of the challenges. And also we also went through some of the literature review where they focused on the impact of the online genetic counseling and how they reduced the financial costing and the waiting times. There's a study that was conducted in Sydney where for cancer patients, and where that online genetic counseling impacted on their waiting time. So basically, normally it's going to take them 2 to 8 hours traveling from their place to the hospital, but with the online genetic counseling, it reduces that time. And our paper basically we're focusing on the comparison between the online genetic counseling and the in-person genetic counseling. Through the pandemic, we also have also compared between the people that they did not have any experience in the in-person genetic counseling. So we provided more quantitative data regarding patient satisfaction and other variables. We're going to talk about them later on. So the methodology, our methodology is a cross-sectional study we conducted to evaluate the impact of the online genetic counseling on patients. It's an anonymous survey that has been sent to the 600 patients to our clinic. 90 from the 600, they responded. The age range between 18 to 85 years, and they were fluently in Arabic. That was our inclusion criteria. So the procedure, basically, our coordinator contacted the patients via email. They sent an anonymous online survey posted by Google Form. The purpose of the study was explained, and a formal invitation for the participation was given. 90 out of 600 individuals gave informed consent and filled out the survey conducted from May 2021 to 2021. So the survey was tested beforehand, and the feedback was incorporated as appropriate. The final survey had 54 questions, all of which either multiple choice or scale based. So the survey algorithm, basically the participants were giving full disclosure before they were sent the links. And also the survey designed to certify participants based on their history of having past experience with an in-person genetic counseling. So basically, for patients who had previously attended the in-person genetic counseling session, the questions focus on the difference in the patient satisfaction and new patient appointment cost and time effectiveness, and other parameters we're going to focus on later on. And for the participants who had no experience in the inpatient genetic counseling, we were focusing mainly on the quantitative ranking of various services provided for them. So the data analysis, we used descriptive such as standard deviation and mean. We're using to characterize the response data by demographics. These are the variables that we were looking at, such as the financial cost, waiting time, satisfaction level, and future recommendation were tested as potential moderators to investigate significant difference between the perception of patients of online and in-person genetic counseling. We also use t-test and Pearson correlation to identify the statistical significance and the strengths of correlation of online genetic counseling, and with the above variables that we just talked about. The results, it was outstanding, to be honest. We basically, the demographics, we had 57 women and 33 men. Mean age was 30 years. 63 participants had requested online counseling for themselves. 27 participants, they were requesting for their relatives or children. 29 from the 90, 29 participants had attended an in-person or face-to-face genetic counseling session. 61 participants were asked about the online genetic counseling because they did not have any experience before with in-person genetic counseling. This is just a summary table that has been for the demographic variables: the age, the gender, the place of residence. If you look at the place of residence, you will see that we've received from the 90 participants, most of them were in the central Riyadh. So the results, to be honest, the results. So by looking at the variables, the satisfaction level. The satisfaction level patients, now we determined by several questions in the questionnaire. So patients who had taken the online genetic counseling reported that they were very much satisfied with their counseling. So we just conclude that there was a positive correlation between the satisfaction level and the online genetic counseling. On contrast, patients who had taken both the online genetic counseling and the inpatient genetic counseling, they reported difference in satisfaction level. So 58% they had certification on the online genetic counseling, and 55% who had the in-person genetic counseling. So the null hypothesis that says that in-person genetic counseling is more satisfactory than the online genetic counseling, this is rejected, which means that this led us to conclude that in-person genetic counseling has no advantage over the online genetic counseling when it comes to patient satisfaction. And also the waiting list, I think this is one of the major challenges that we were facing during the clinic. So basically with the waiting list, 69% of the patients reported that it was very easy for them to schedule the session in the online genetic counseling through the platform. And 65% reported that they did not have to wait for more than 24 hours to have an appointment with the counselor. Compared to 31% patients reported that it was very difficult to schedule an appointment for the in-person genetic counseling session. It took them to 6 months for the appointment. When we look at the emotional support and reassurance, this is very tricky, because usually when you say emotional support, you would think that having the patients in front of you in a clinic, you will feel their expression, then you will have more contact with the patient. But through our study, we found out that there is a correlation between having an online genetic counseling and an emotional support. There's a high significant correlation, and maybe because people, when they have an online genetic counseling, they have more privacy and they have more time, and they can recap the information whenever they have any question. It pops up in the middle of the day. They just can log in the platform, and then today they can ask the question. And also, definitely, online genetic counseling have helped through the pandemic, because as I mentioned in the earlier, that there's a lot of clinics that have been shut down, and with the online genetic counseling, we were able to help a lot of patients, explaining to them their genetic testing. Even we had like premarital screening requests, and also ease of booking. As I mentioned, it's very easy to book your online genetic counseling. It's comparing to the in-person genetic counseling, you would have a lot of you have to wait for at least 6 months to have an appointment. Definitely reduction for financial costs. You don't have to travel all the way from your place to the clinic, especially in Saudi Arabia, where all the genetic counselors, mostly they are in the central Riyadh, and so people around the country, they have to travel all the way from south, north. They have to come to Riyadh to meet with the genetic counselor. So with the platform, I think that will help a lot of patients to reduce their costs, their financial costs, and even the traveling time. Reduce the anxiety. Some patients, they feel very calm when they have their own privacy, and then they can contact with the counselor without even having face-to-face. I have to mention that in the platform, it's either you can contact the genetic counselor through typing your request, or even you can send a voice note. We also have an updated, which is a video calling, where you can have your full session, the pre and post session, by video calling with the patient. These are just a table just to demonstrate the numbers for the statistic that we have been using, the mean and the standard deviation, the correlation, the t-test, and the p-value. So definitely there should be a limitation for each study, and there are 3 limitations I could mention here in our study. The first limitation is the result may not be generalizable to a global audience, as people all over the world belong to different socioeconomic classes and medical risk levels. And that's number 1. Secondly, our cohort consisted of patient at your genetic counsel patient who had experienced in-person genetic counseling in the past with a provider, and we're not taking online genetic counseling at your genetic counsel. We're asked to compare both their previous and current perspective on the 2 medium of genetic counseling, and patients who had never taken genetic counseling in the past were asked to give their perspective about online genetic counseling, and therefore I think that could be considered as an inherent bias in the participant toward in-person genetic counseling. Number 3, which is our cohort also consisted of Arabic-speaking educated counselee, and the research was a single-site study, so therefore we cannot apply to a diverse population and or reflect other research. However, I just want to summarize my presentation. So participants who received online genetic counseling reported higher level of satisfaction and convenience than in-person genetic counseling. As our data suggested, reduced appointments time, short traveling distance, less financial costs, better knowledge about the genetic disease, and protection from COVID-19 due to not repeatedly visiting hospital are some of the factors which drive people to choose online genetic counseling instead of in-person genetic counseling. The world today is moving toward digital age at an accelerated pace due to the global pandemic. Our quantitative data can be used as a starting point for future researchers to investigate methods and strategies that can be implemented to improve the issues in online genetic counseling. Thank you so much, and I hope you enjoyed the presentation.
Thank you so much, Ms. Fawz. That was so great. There is a question. How likely you would recommend online genetic counseling to a friend or family member? Nadine, would you reveal the results, please? So around 49%, they were extremely likely to recommend online genetic counseling. Would you like to comment on it, Rose?
Yeah, so I think that's a good news, صراحة, alhamdulillah. And I think because as we mentioned, future technologies has an impact on the shaping of the healthcare sector. And I think since I explained the reasons why online genetic counseling has an impact on the genetic counseling services for different reasons, I think this is a very good answer. And I'm really glad that it came out as this.
That's so great. Last but not least, we have the last speaker. Will tell us about how it's like to live with a genetic condition. Dr. Nikki Tavener is a registered genetic counselor working for the NHS, All Wales Medical Genomics Services in the UK. She is also the Deputy Program Director of the Master's Genetic and Genomic Counseling at Cardiff University, and the chair of the Association of Genetic Nurses and Counselors in the UK and Ireland. Dr. Nikki, my sincere apologies for the delay, and you may start your talk.
Thank you, Munira. That's no problem at all. Good evening, everybody, and thank you very much for inviting me to do this talk. I am aware it's quite late, so I will try to keep it quite brief, but I think we've had a really fascinating evening of talks. And I think what I'm going to try and do is sort of draw back a little bit. We've talked about the practice and challenges of genetic counselling, and now just to think a little bit about what it's like for our patients. So a lot of this will be familiar to you, but hopefully it will just help us to think a little bit more about what we're trying to achieve in our genetic counselling in order to meet our patients' needs. Okay. So as you know, living with genetic conditions can have a huge impact on patients and their families, and therefore also on our society as a whole. And that impact occurs throughout life. So from birth through all of those significant life stages that we will pass through all the way to the end of life. And the reason that we do what we do is to try and help patients and families to adjust to what they're dealing with and to make choices that are appropriate for them and for the society and culture in which they live. So the way I've thought that we might think about this is just to talk through a few conditions and think about what impact they might be having on a family. And a lot of this comes from my personal experience and my work with patient support groups, but also my work within the UK generally, and also a lot of the research. So some of it is very centred on the UK and also the other places where a lot of research has been taken place into the impact of living with conditions, so places like Australia, America, and so on. But of course, the learning that we get from this will be similar for people living, for example, in Saudi Arabia, that there will be differences depending on the culture and the values and the way in which the society works, as well as the legal structure in which the country functions. But we always think about genetic counselling helping individuals and families to accept and adapt to the impact of genetic conditions. So thinking about these aspects, as well as the scientific and medical implications that we've also been talking about this evening. So starting with one particular type of genetic condition, so the inborn errors of metabolism, which of course are relatively common, for example, within Saudi Arabia, but also elsewhere around the world. And if these aren't diagnosed, or if they're not treated or can't be treated, and this can lead to many problems for the individual, but specifically thinking about leading to developmental delays, where children are not able to achieve those milestones and develop as we would hope our children will. And therefore they need that added level of care, which is quite a burden for the family, especially for whichever is the main caregiver within that family. And that can cause strain on the family unit. So it's not just simply about dealing with that particular individual and helping them develop and have the care, but what about the impact on mum and dad and brothers and sisters and wider family, grandparents, uncles and aunts and so on? And what impact does that have on all aspects of their life? So if this child needs high levels of medical care, that can restrict daily life and the activities that people choose. It might have significant financial implications. They might have lots of medical appointments they need to go to. That's going to affect everything else that's happening. And this is going to impact on the whole family, and especially, of course, on the primary caregiver. So they might, for example, need to restrict their other activities and provide care for that child. They might need to reduce their employment. They might not be able to work as they were before, perhaps. And so that's got implications for them and for the family. They're no longer bringing in that additional money. And also for society, you know, in our employment, we're contributing to the society as a whole. And if people aren't contributing in the way they may wish to, that has an impact on the society. And so we need to be thinking about that altogether, not just thinking about the care for that individual and the caregiver. And then thinking about some of the particularly strong aspects that may come up for people, the kind of emotions that they may experience. So when parents have a child, they often have a sort of image of what that child's life will be like. They imagine the child growing and developing, you know, going to attending education, developing a career potentially, possibly being in a relationship, getting married one day, having their own children. And that may not be possible if that child has this significant impact because of these conditions. And so we know that parents can experience quite a strong grief reaction at the loss of what they sort of expected to happen for that child. So they're not grieving for a child that has died, but they're grieving for what they saw their future being and it not actually happening. And they may question why this has happened to them. And that, of course, impacts on faith and values. And so it's very a holistic impact on all of their life and thinking about how they adjust to that. And alongside that, they may also be adjusting, when we're talking about genetic and genomic conditions, to the risk of having more than one affected child. So lots to think about there for them, about what that future might hold and what this means for them and the way they see their lives developing. And then also the impact on other family members. I've just put in about siblings here, brothers and sisters. So they may feel quite angry towards their parents if they feel the parent is having to provide additional care for this child that has these additional needs. And that can have an impact on mental health. And, you know, I think there's a strong understanding about the issues around mental health that have been growing globally and thinking about people needing support. And we need to be aware that this kind of strain on the family unit can impact on mental health. And what we also know is this can be a very positive thing for siblings. And often there's evidence that they are very caring individuals with increased empathy for others, having grown up with a child who perhaps needed some additional input. But there can also be resentments which affect that family. And so when we're doing our genetic counselling, we're trying to think about the family as a whole. So not just the specific problems or the science around what's happening for the individual in front of us and their parents, but also trying to help them adjust to that new reality for them and achieve the most positive outcome for the family as a whole. And of course, with some inborn errors of metabolism, we are able to provide treatments and we're able to therefore reduce some of this impact. And so that obviously can be a very positive thing for families. But there's also, again, quite a lot of research and again, something we've seen in practice about that can still be challenging to achieve. So for example, if they need a restricted diet in order to achieve the goals that they're hoping for, that can be challenging for the family and lead to tensions and difficulties within the family. And particularly around the time that the child is becoming more independent, so around sort of adolescence, late adolescence, we know that can be a time when individuals rebel a little bit more around family restrictions. And if they then start not following this diet, that can lead to problems for their health and can lead to significant issues in terms of their brain development and bringing in problems like that, which then causes problems for family relationships as parents are trying to protect their children. And so I've just pulled out that as one particular type of genetic condition, but just to help us think about that holistic impact and how we can help to ameliorate that when we're working with these families to help them move forward. And thinking about not just about children who have these specific problems around inborn errors of metabolism, but another common condition, so sickle cell disease. And so what kind of impact might that have? So a different type of genetic condition. So here I've particularly focused on the impact on education and career, although obviously there's huge impacts generally on all aspects of life. So because individuals have these extremely painful crises, they may be unable to attend school or to work. They might need to go to hospital to manage those painful crises. And these can occur very commonly, as you know. And therefore that means that they are reducing their access to that education or to employment, and that can significantly curtail their opportunities. So again, this is important for them and important for their family, but it is also significant for the society as a whole. And that's why I think we all want to take responsibility for helping as far as we can for these families to adjust and ensure they're able to live the best life that they can for their own personal benefit, but also because that fits with our values and benefits society. And thinking about particularly people when they're younger and may want to be taking part in usual activities of life around their education and career, so not just going to school, but taking part in some of the other aspects that are really important for personal growth and development. They may be unable to do that as well due to these painful crises with sickle cell, and that can affect their mental health. So these really can impact on every single aspect of life, and that's something we try to think about in our counselling. And thinking about the hemoglobinopathy still, of course, that can impact on marriage choices. So of course, there's premarital screening taking place, and therefore that can impact on who people choose ultimately to marry. And that can have quite a significant effect. So this is limiting what options they may have and who they may be suitable to marry. It's not just, again, about education and employment, but also about those fundamental life choices. And in terms of marriage, with those fundamental life choices, they can occur in different ways as well. So of course, for the majority of genetic and genomic conditions, there aren't things like premarital screening. But for things, for example, that are inherited in a different manner, so for example, autosomal dominant inheritance or X-linked inheritance, somebody who has an autosomal dominant condition, that there's a 50-50 chance they pass it on to their child, or a carrier of an X-linked condition, where there's a 50-50 chance that they would pass it on to any sons that they may have. That's quite a significant thing to deal with, the fact that they're going to potentially pass this on to their child, which might have a very significant impact on their life. And that may also cause a stigma. So that may mean it's harder for them to marry, for example, because potential partners may be concerned about the risk to their offspring, so the risk to their children of having these particular conditions. So I pulled out the example of X-linked conditions here of congenital hydrocephalus. And so the sisters of those affected with these conditions could be carriers, and therefore there may be a stigma, meaning that makes their marriage choices more limited because people are concerned about the risk of passing this on. It's worth saying that stigma is still very significant for many genetic and genomic conditions. And it's also worth saying particularly that can be the case around some conditions that can be associated with problems with mental health and mental illness. And there's an increasing awareness of the role of genetic and genomics in mental health. And therefore that can, again, lead to difficulties for individuals when they're looking for their life partners. So we've talked already about the possibility of passing these things on to children. So what about the impact on reproductive options? And of course, the reproductive options available to couples will vary depending where they are in the world. We've touched briefly in one of the earlier talks around reproductive options and what they might be within Saudi Arabia. And they will vary in different countries. So we're thinking about the law, but it's not just about that, is it? When you're trying to make a choice about reproductive options. So if you were seriously considering having a test on a pregnancy and having a termination of pregnancy, you would need to think first of all whether that was legal, but it's also about how that fits with your faith, your belief, and your values. That may be completely unacceptable, and you may feel that's just not an option for you. So even if you know that there's a risk that you may pass on this condition, what decision do you make? Is it that you decide not to have children in the first place? Is it that you take the risk that you may pass this on? Or, for some individuals, they may think about options around testing and termination. And it's worth saying as well that these views might differ between a couple. So, whenever you're thinking about having a child, you've got both parents and they may have slightly differing views on this. And that can be a significant cause of strife for the individuals within that couple, but also the family values as well will impact upon that. And so if a couple is seriously considering something around prenatal testing and termination under situations where that is legally allowed, that doesn't necessarily mean that it will be acceptable within the family. And that can cause significant tensions for the couple and their wider family. It's worth saying there, I've touched on it earlier about the fact that genetic counselling is trying to help people adjust to the impact of these conditions. And that's an area certainly where very significant support might be needed when trying to make difficult decisions around these kind of really fundamental options about whether or not you consider ending a pregnancy when it was legally, you're legally able to do so. And then moving on to different types of conditions. So perhaps things that don't affect you at a younger age, or not thinking so much about reproduction, but thinking about conditions that might affect you when you're older. So progressive neurological conditions are a significant one. Genetic counselling kind of really started around what kind of provision of testing for people who are at risk of developing Huntington's disease later in life. So these progressive neurological conditions might develop in adulthood and lead to significant dementia, and therefore have very significant impacts on the future for individuals who know that there's a family history of this and that there's a risk for them. And individuals can really struggle with knowing that they're at risk because they're frightened about what might happen to them in the future. And they may struggle to make difficult decisions about how best to live their lives with that risk hanging over them. So it's difficult for the individual who knows this might be the future for them. But also once they may start to develop those conditions, families may also find it difficult to keep them safe. When individuals are developing dementia, it can be difficult to ensure that they are safe and they're not putting themselves or others in risk. And so families are then under a lot of pressure to manage that appropriately in order to provide care for their individual who they very much wish to support, but it may not be possible for them to do so. And so that puts a huge amount of strain on the family unit and can lead to a lot of tensions within families about how best to provide that full-time care. Would carers be acceptable? Would they be coming into the home to provide care? Would it even be, is it even necessary for them to go to a hospital or somewhere to have more ongoing care? Or does that feel unacceptable to the family? So lots of difficult decisions here, which of course aren't specific just to genetic and genomic conditions, but often can be sort of very common within these kind of conditions. And you have the added complexity of the fact that it might be more than one family member that you're thinking about. So just a few examples there to think about the impact about living with genetic conditions and thinking, but not just about the affected individual, but also about the people around them and how it impacts on them. So their family specifically, but also friends and also wider society. And there's really strong emotions and difficulties that may arise around these kind of conditions. I've just put a few down here. So grief and loss. So it can be grief because people have passed away due to these conditions, or that grief for the loss of an expected future, or a child that you saw living in a different way. Resentment within the family, frustration and difficulty. You're not able to achieve what you want to achieve, or the family isn't able to do what they want to do. That big issue around stigma around some genetic conditions, and also fear of the future, fear of affecting children or potential future children, fear of things impacting marriage prospects. There's a lot of difficulties around these conditions. And I would argue that's why genetic counselling is so important. We can help with the scientific aspects and we can help with the medical aspects. But what we also want to do is address these more psychosocial issues in order to support our patients, to help them really come to terms with what the risks may be or what is happening for them, help them think about what is best for them, what fits with their beliefs and values, with their family, with society as a whole, and adapt to that and live the best possible life that they can. It's worth saying as well that we only have limited contact with many of these families. I would argue there's still a lot you can do, even in that short session, to help people to come to terms with this. But longer term support may also be required. And certainly within the UK, we work very closely with sort of patient charities and support organisations. And families often benefit hugely from talking to other families who are experiencing similar conditions or who have been through things before, and they can also get more professional support if needed. So as I say, I'm aware it's getting quite late, so I was going to end there. Hopefully I've kept a bit short of my 20 minutes to capture a few bit of time. But I hope that's just helped to draw the session together to help us think about the patients. Thank you.
Thank you very much, Dr. Nikki, for this fascinating talk. We have some questions. Ms. Khawla, can you please recommend some good books or sources for cytogenetics counseling?
هلا منيرة. There are many books بصراحة مو حاضرني الحين. في Atlas of Genetic Diagnosis and Counseling, في Chromosome Abnormalities and Genetic Counseling, Foundation of Prenatal Genetic Counseling. There are many there.
Thank you very much. Ms. Sarah, are you with us?
Yes, Munira.
Hi, Ms. Sarah. Apologies for cutting you off. I just received Dr. Amali. They didn't hear the notification. I'm really sorry. We have a question for you about is it available? The lecture, is it available to share?
Yes, I can share it, Munira.
Thank you very much. Thank you very much, Ms. Sarah. And now we have Amir Jamhawi. He's a geneticist and the sales manager for Centogene at Riyadh. He will give 5-minute talk. Mr. Amir, can you hear me?
Yes, I can.
You may begin.
All right. I would like to share my screen, please. Thank you. Can you see it, please?
Yes, it's clear.
Okay, perfect. All right. First of all, allow me to, good evening, everyone. Thank you for giving us the chance to present this talk about our improved Centoxome in this esteemed symposium. On behalf of all MEA team, my name is Amir Jamhawi. I'm a medical geneticist by training, and as Mrs. Munira said, I'm the regional manager at Centogene for the Central Region. Now, usually it takes around, on average, around 7 years to diagnose a patient with a rare disease. And as Dr. Nikki touched on, without a correct diagnosis, not only there is the emotional and social aspects, it is difficult to receive the correct treatment, leaving patients and their families searching for answers in a race against time. Now, as part of Centogene's commitment to the diagnostic odyssey for rare diseases, we have taken the responsibility to turn the years into days by introducing our new and improved Centoxome. The new Centoxome launched by Centogene will offer the best-in-class insights based on the superior technology and knowledge from the experts in omics testing, coupled with a long life support from the leader and trusted partner in rare disease diagnosis. Now, what are the key features that we integrated in our, as standard in our new Centoxome? Now, first of all, the excellent and uniform coverage across the entire exome. We're talking about the 20,000 genes at an average depth of 20x and more than 99% sensitivity. Also, boosting of clinically relevant regions. Okay, let me turn on. Okay. Regions linked to 8,000 clinically pathogenic and medically associated genes. The boosting will be articulated internally through our expert leveraging on our CentoMD database, which is the largest database in clinical variants of clinical variants in the world, along with other public databases such as HGMD, OMIN, and others. Now, coverage of disease-causing variants within the non-coding region, also leveraging on our CentOMD, and complete mitochondrial genome analysis. Now, if we boil down the differences between the old centosome and the new centosome, you will see the valuable and unique key features, along with the superior technology that will be offered as standard through the new centosome, thus increasing the diagnostic yield and it is summarized in this table. Now, if you compare the old centosome with the new centosome, you will find out that we have added as standard all the key features that I mentioned before, including the mtDNA, the boosting of the clinically relevant regions within the deep intronic region, all the SNVs, CNVs, UPDs, and mtDNA variants. Now, from all the above mentioned, we were able to increase the diagnostic yield up to 60% by including the SNVs, over here, including the SNVs, which increased the overall diagnostic up to 30%, 15% when we included as standard the CNVs, 5% mtDNA. Now, to conclude the presentation, all the information regarding our portfolio can be accessed and obtained through our website, which has many information not only about the products, but also educational materials directed to both the physicians and the patients. Thank you, and if you have any questions, I'll be more than happy to answer.
Thank you very much, Mr. Amir. Dr. Ahmed.
Thank you very much, everybody, for your attendance and being patient with us till now. We know that it is late time. Thanks the panelists, thanks our speakers. It was really amazing and great lectures. Thank you, Jawahir from Infotex, for your helping us in the management of the administrative and technical point in the Infotex. It was really great to work with you as usual. Please, if you have any questions, you can write it in the Q&A answer. I see some of the doctors who are raising their hands. Dr. Hani from the beginning, Dr. Khalid, Dr. Marwa. Kindly, if you can write your question if you have any question and the Q&A, and we are so happy to answer your questions. And Amira, do you have also the last housekeeping things? How they will get the certificate and etc.
Yes, they need to fill the survey, and they will receive it on their emails, and they will get the certificate. Sorry.
Okay.
Dr. Hani Afghani, would you like to talk? You can talk.
I would like to say thank you so much for everyone and for holding such events. I'm sorry, by mistake in my hands, I realized Dr. said Dr. Han is raising his hand up. So I'm very sorry.
No problem.
It's a great chance, by the way, to say thank you for everyone and for this events, to be honest. Thank you. Thank you so much.
Thank you so much, Dr. Hani. It's an honor to be here in our webinar.
Okay. Okay, thanks for others. And we need to close now because it is time for us to end and to say thanks again for everybody. And hoping we will see you later on our SSMG activity. We have our club meetings and annual meetings. And please, if you like, You can follow us in the SSMG_genetic, our Twitter account and Instagram as well, to follow and to have the update and all the activities of SSMG. And we are proud to also, it's our pleasure, to have you as a member and to have all what suggestion you have for us to improve the activities for us and for awareness, giving awareness for the healthcare worker as well as the community. Thanks a lot. Have a nice night and please take care of yourself. Keep distance, social distance, and take care. Thanks a lot. Good night. Nadine, are you around? Some people is asking when the survey will start. Once they leave, the survey will start, isn't it?
Please scan the code to answer the survey.
Okay. So they will scan this code.
Yes,
Joanne,
it will be. Yes, it will be on the screen for the next 5 minutes. Please scan it and fill the survey.
Yeah. Okay. So this who ask Nasrat, please scan the code which is in the screen. Dr. Zoher Rahbini is asking about the cost. 75 riyals, Saudi riyal.